platelet receptors change when they are inhibited by antiplatelet agents. So we don't actually, there's a lot about anticoagulation and platelet aggregation and activation that we don't really know. From what I read, you know, it's not entirely clear, but those platelet receptors actually are, a lot of them are G-coupled proteins, meaning they're internal until they're activated and then the receptor becomes external to the cell. So those really happen with there's certain things that cause that to actually happen. But the drug itself, overloading the receptors, doesn't change the number of receptors on the platelet. Generally, from what I was able to find, that the platelet is born with the same number of receptors. And remember, the platelet only lives for 7 days. So it's different from receptors in other areas of the body that are present all the time, right? And those receptors may be turned over at different volumes or different time periods, but the platelet's only around for 7 days. So the receptors that it has, you know, whether it's inhibited or not, don't necessarily change all that much regarding whether or not they up and down regulate. It's really whether or not they're activated and stimulated to the conformational change that has to happen in order to actually allow the receptor to bind, or the drug to bind, or the agonist to bind to the receptor. All right? All right. Any other questions from last week? No? All right. So you guys are all, everybody knows their antiplatelet drugs? Not at all. Not at all.
I'm just kidding, I know some of them.
All right, so a couple of keys to pharmacology is, and really most things in my opinion, obviously everyone's going to study a little different, you're going to study a little different for each course, but repetition is really important for pharmacology. So when you come to my class, it's really a good idea to try to at least brisk through the lecture before, so things that I'm talking about are not completely foreign to you. Okay, so at least read through the lecture and, you know, skim through the lecture. So maybe you put aside 30 minutes to do that before class at some point in a couple days before class. Then you come to my class. You try to stay engaged as much as possible. The dodgeballs help with that. And then after class, preferably the same day or the following day, you look through the lecture again and you realize what were the concepts that just went totally over my head because I was shoe shopping, or I was tired and falling asleep, or I just didn't make sense to me. Flag those concepts in your notes and then either make an appointment to see me outside of class to talk about it, or try to figure it out on your own, and then still if you don't get it, then come see me. Charts are super important for pharmacology. So on a chart for pharmacology, what do you guys think are the important things that you should have in the chart? Because making useless charts is useless, right?
The route and the mechanism.
Okay, so first the drug.
Oh yeah.
Okay. And we have the generic, preferably first, because that's really what you should know. And then maybe you put the brand too. Okay. Absolutely. Mechanism of action.
Side effect.
That's later.
The route and administration.
Half-life.
And you can actually put like important like pharmacokinetics, pharmacodynamics here. Right, so you maybe like if the half-life is like, you know, really important, but you also want to put some other pharmacokinetic and pharmacodynamics, like maybe it's a prodrug, where is it excreted and metabolized, the route. Sure. And I probably would put the route here.
What about the type of drug? Like,
Yep, class. So over here, and I missed that, over here you should have the class of drugs. So you should have all the ADP inhibitors, right? All of your G2B3A inhibitors, so that everything's grouped together, right? Maybe you do that by color coding, right? So maybe you have these three, and they're all your ADP inhibitors, right? So that you're grouping things together so things start to, oh, I'm looking at things together. Okay, what else do we want to put?
Should you put like contraindication?
Yep. So side effects, contraindications, or things like a black box warning. If a drug has a black box warning, you better know it. So what does that mean? Huh?
Like if you do it, something extremely dangerous could happen.
So there's been an FDA warning, right, that has been sent out or alerted to the general public as well as providers saying that a number of people had this adverse effect that was potentially life-threatening or really serious. Right? Can anyone think of an example of a black box warning you've learned about so far?
Well, tobacco, smoking causes cancer.
Okay, yeah, so that's definitely a black box warning on cigarettes. But what about a drug?
I remember from dermatology, like Elidel, but I forget
Okay,
something
that's
about it.
yeah. So the FDA black box warning has actually now been repealed, but good. So that what is Elidel?
What's the topical? I can't.
What about something you've learned about in pharmacology so far? What about Viagra?
Nitro. Don't take it with nitro.
Good, good. Why?
Good.
Good. So it causes hypotension and
Right.
can cause vasodilation, syncope. Right. Good. Was there anyone else?
Oh,
Anybody
I
else?
was thinking about the drug you told us about last week where you said we aren't supposed to give this people with heart failure.
Good. Yes. Very good. So the study was actually done on what drug?
It was.
So it's actually done on milrinone, right?
Yeah.
Which is an inotrope used to actually treat certain types of heart failure. And cilostazol, which is a PDE inhibitor, actually has a similar mechanism of action, right? And so they presumed that potentially there could be that same side effect and could actually worsen heart failure in certain cases. Okay. Good. So that stuff all is really important to put up there, right? So what's the class of the drug? Keep those together. What's the generic brand? What's the route? What's the mechanism of action? How does it work? Is there anything special about it? What's the half-life? How is it excreted and metabolized if that's important? What are the side effects, contraindications? And then for these drugs that I'm teaching you about, I would also put over here, and you might want to add it into the half-life or add a second column, is how long biologically is that action of that drug? So if I had to ask someone to stop it for a procedure or a surgery, how long should they hold that drug before it's really out of their body, right? So some of the drugs that we use for percutaneous coronary intervention, which we know the half-lives are really short, obviously once we stop the diffusion of that drug, it's out of the system quickly, versus someone that's on aspirin, we need to stop that much, many days before the surgery because we know the biologic half-life of the drug is much longer than the actual half-life, okay? All right, so this is a really good way. This is what I did in PA school to really remember, and I would do it with every single pharm lecture. So now, even now, I use those tables sometimes to look back at, and if you don't use each other's tables. Making the table is part of the learning experience. Don't just pull a table from online, right? Someone else's table. If you're going to do that and use it as a reference, that's fine. But making the table your own is part of the learning experience of it. So, some people will just, only one of us is going to take notes during the lecture, and then we're going to post it on the Google Drive for everybody else. Not really super helpful, right? Because you need to be engaged in your own learning process. You need to make your own tables. Yeah, sure, you can share them with your class, but you guys really need to be doing it on your own because that's really much more beneficial that way, okay? All right, so today we're going to talk about anticoagulants. So last week we talked about the first part of clotting, which is really the platelet, right? So platelet activation, aggregation, and the clotting cascade even starts to happen during that process, we said, which is predominantly done by... Bradley, wake up.
What was your question? Again? I heard it, but I didn't hear it.
Okay, you're tired, but you gotta stay engaged. So when the platelet aggregation and activation is happening, right, that's the first thing that's helping clot formation. But the coagulation cascade is being stimulated in that process as well. Through what factor?
Is it, when you say what factor, is it like only one factor?
There's only one clotting factor that really starts the coagulation cascade within platelet aggregation itself.
Is that
Yes, which is what factor?
Is that, it's not 12.
No, not 12. Close though.
It's 8.
No. 2.
Two.
Right, 2. So take the 1 out and just keep the 2. So you're thinking common pathway, right? 12 comes soon after that, but 2 is thrombin. Prothrombin to thrombin is 2. Okay.
I like this.
Yeah. You want to do that? All right. So you can keep it
I'm
a little
gonna
weight. You can
squeeze
keep
it.
it for a little
Yeah.
bit. All right. So What factors can be targeted using anticoagulant therapy to prevent thrombosis, Tolu? So now we're shifting gears. So I want you guys to mentally shift gears. So we're shifting from platelets, we're shifting to coagulation factors. So what can we target? Think about areas that are really crucial and critical to the clotting cascade, and what can we inhibit?
2, 7, 9, 10.
Okay, what does that?
Vitamin
Vitamin K.
Inhibitors.
Good. So what is a vitamin K inhibitor? Warfarin. Very good. Okay, so we can inhibit 2, 7, 9, and 10, which is a more broad inhibition. What else can we inhibit? 7.
Yeah, I just remember heparin inhibits 10.
Okay, does it only inhibit 10?
No, it doesn't. This is the one that's most effective.
So your top, so there's 2 different heparins.
Yes, there's the only.
Okay, so there's unfractionated heparin, and then there's low molecular weight heparin. So unfractionated heparin, which is our oldest version of heparin, inhibits both factor 10 and factor 2, which is thrombin. Yes, good, okay. But once we go into the low molecular weight heparin, Maureen, what happens? We'll get there.
Okay.
We'll get there. I don't expect you to necessarily know all.
Don't you inhibit?
Where else can we target?
No, wait, no, I was asking a question. No, I was saying with the low molecular weight heparin, you inhibit more factors, right? Versus the unfractionated, or is it opposite?
Less.
It's less,
Yeah,
okay.
we'll get there. We'll get there. I don't expect you to necessarily know that yet.
What was the question?
So what other factors? So we can inhibit both factor 10 and thrombin together.
Yes.
We can in factor 2, 7, 9, and 10 together.
Yes.
Or we can inhibit what other factor? Alone. Yes, thrombin, right? So factor 2.
I thought we already said 2.
Well, we said that we can
Oh,
inhibit with
together.
heparin. We're
Okay.
inhibiting both thrombin and
You said 2 and
10.
10.
Right. So
Okay.
thrombin and
Thrombin and I don't know what 10 is.
well 10. Yeah.
Oh,
so
okay.
10
Okay.
and thrombin.
Yeah.
So 10 and thrombin.
And then-
Right. Or we can inhibit.
You said 2, 7, 9, and 10.
Okay. So that's with vitamin K
Yeah.
inhibitors.
And then, I don't know, so 2 by itself, 2 and 10. And then,
Right. So we can inhibit
Okay.
10 by itself,
uh-huh.
2 by itself,
Oh,
or
okay.
2, 7, 9, and 10.
This is too many numbers.
Yeah. I know. It's a lot of numbers. Good. Okay. So the other thing that we can inhibit, which is really what you're talking about, which by heparin actually inhibits antithrombin. Okay, so antithrombin then further inhibits vitamin 10A and thrombin. Okay, but it's not directly inhibiting thrombin and 10A. It's inhibiting by activating antithrombin. Okay, and we'll get there. All right. What drug is represented by letter A? Cam. So letter A is inhibiting 10A and thrombin. Good. Very good. All right, and we'll talk about more specifically which ones inhibit more of one than another, but I don't expect you guys to know that yet. What is represented by B? Emmy. All right, so B is inhibiting what factors? Good, very good. So warfarin, which is in the class of vitamin K antagonists, or VKA. What drug is represented by C? So particularly inhibiting thrombin, so our direct or indirect thrombin inhibitors. So antithrombin is not specifically only inhibiting thrombin, right? So it inhibits thrombin and 10A for our heparins. But which drugs are direct or indirect thrombin inhibitors that are other indirect or direct thrombin inhibitors? One of them is, there's only one oral one. So no drugs that we talked about last week are we going to talk about today. So that's just a big clue, at least for in the purpose of the anticoagulant lecture. All right, so there are some oral anticoagulants that are new onto the scene in the last 5 to 10 years. Until recently, we had no other oral anticoagulants except for. No, heparin's not oral. Warfarin, yes. So warfarin is this ancient drug with a lot of side effects. I'm not saying it's not a good drug, but we had no other options for anticoagulants until recently when this drug came onto scene. All right, so let's have like an honesty moment.
I know what you
Who actually looked through the slides for today? Right now. And you have no idea?
So don't call on me. Don't call on me today, because is it a
So argatroban is, okay, also, so like the Herudins, argatroban, and then what about the NOAC?
Oh, no, I want to ask a question.
Okay.
Okay, you said warfarin inhibits 2, 7, and 10.
9 and 10.
9 and 10, but then the new warfarin inhibits only.
No, so the new drug that has replaced
has
warfarin
replaced.
in a lot of cases. Now, we're still using warfarin, don't get me wrong, but we have a lot better drugs now that are called NOACs, or novel oral anticoagulant drugs, right? That we're using now that have replaced warfarin in a lot of settings, and one of them that was the newest onto the scene is called dabigatran or Pradaxa. Yes?
So why would we still use warfarin?
Well, I'll talk to you about that a little bit more later, but yes, cost is definitely an issue, and there's some other reasons. So anyone that looked at the slides, can you think of another reason why we use warfarin still, other than cost?
The allergies or like allergies?
No, so there's not a ton of allergies to dabigatran, but there are a few contraindications or reasons why we can't use it.
When you say it's more general?
When you say general,
Like it affects them.
well, it affects 10, right? So, I mean, it affects thrombin. So, I'm sorry, dabigatran affects thrombin, the 10A inhibitors affect 10A. But it is affecting thrombin, which affects everything, right? So, it's not that it's really more general, but up until recently, there was no antidote for it. We now have an antidote for it. There's always been an antidote for warfarin, which is vitamin K, right? So, or we can give fresh frozen plasma or cryoprecipitate, right? That's actually giving the factors. You want to come up?
What? No, I just said fresh and have retardant.
That's true. But in addition to that, you have to renally adjust the drug if patients have renal failure. And it hasn't been studied in patients that are obese or severely obese with a BMI above 40. So there are certain populations we can't use those drugs in. And like, because they're so new onto the scene, only recently, as of a couple of years, they've expanded the indications for those drugs. So they really started out as prevention drugs for clots in patients with atrial fibrillation. And then as we've studied the drugs more and more, we've started to actually use them for treatment of things like DVTs and PPs and clots. But the problem is there's really no good monitoring for those drugs. Whereas for warfarin, we know that we can monitor the effectiveness of warfarin by what, Christian?
You caught me in the curve.
I know.
INR. Measure the PT and INR.
By INR, which is also called, so it's the internationalized ratio.
Oh, is that V proton? No.
PT, which is prothrombin time. Prothrombin time, right? That's prothrombin is what converts what's the inactive form of thrombin, right? So that needs to get converted to thrombin to be active, right? So prothrombin time, or the INR, is used to measure warfarin, and we can tell how effective it is based off of the INR level. What INR level would be considered to be therapeutic, Annette? No. 2 to 3 is considered therapeutic for most indications. 2.5 to 3.5 is considered therapeutic for patients that have heart valves. Okay, so mechanical heart valve, a little higher. But generally 2 to 3 for almost everything else is considered to be therapeutic. Whereas for our NOAC agents, as we're going to talk about, is that there's really no great monitoring, and so it's hard to know. Every patient's going to be a little different. So it's hard to know what's, you know, if they are over anticoagulated or under anticoagulated, if they don't really fit into the narrow window of who we study the drug in, right? Because we know that drug pharmacokinetics and pharmacodynamics are going to change somewhat based off of age, gender, race, you know, CYP enzyme metabolism, renal function, liver function, right? And so it's hard to really account for all of those when you do a clinical study, right? Yes, somebody back here.
Oh, so I was just curious, like, is there like a patient population that would not reach in with warfarin? Or are there like lots of contraindications? Like, what was the need for the new drug?
Yeah, and we'll get there.
Okay.
So yes, there's a lot of issues with warfarin
Okay.
for sure. First of all, does anyone know what warfarin is?
Rat poison.
It's rat poison. I'm sorry, glad that at least you picked that. Yeah, so it's rat poison. Okay, so obviously, you know, not a drug that is free of other side effects, and we'll talk about why. All right, so dabigatran, carudins, and argatroban. So this you guys can use as a little bit of a reminder of which drugs are inhibiting what areas, and we're going to go over those in detail, but this was just a little bit of a pre-test. So we already talked about which test is used to monitor efficacy of warfarin. But what about which test is used to monitor efficacy of low molecular weight heparin? So low molecular weight heparin is different than unfractionated heparin. So unfractionated heparin, we said, inhibits thrombin and 10A. But low molecular weight heparin actually doesn't inhibit thrombin as much. It only really inhibits, to the greater effect, 10A. So we have to actually check anti-10A levels to measure efficacy of low molecular weight heparin, and you will learn why very soon. So really important. So we just said which test is used to measure unfractionated heparin, that's your PTT, okay, because it's inhibiting both thrombin and 10A. What is considered a therapeutic INR? We said 2 to 3. Very good. And remember, I always like for you guys to know what the actual standard units is, but 2 to 3, because it's the INR, there really is no, that's the internationalized unit. There's no other unit associated with it. What electrolyte is crucial in the clotting cascade, Eden?
So unfractionated heparin, we use PTT, and then low molecular weight heparin, also.
What factors are calcium dependent, Vinny? Okay, we got one.
No.
Actually, 8 is not calcium.
9 is
9. Technically, if you're talking about protein CNS. So what is it? So we have 9 and 10. 2, 7. 2, 7, 9, 10. The same vitamin K dependent factors. And then protein CNS are also calcium dependent. Protein CNS inhibit 5 and 8, so you could include 8 on there. Although I was
Is that what you were talking about in diagnostics?
Yes,
What is
we're going to talk all about it.
All
Yeah,
right.
sorry, I'm jumping ahead a little
Okay.
bit. I'm just giving you guys a little preview, but we're going to get into this really quickly. What other pathway is associated with these factors? 2, 7, 9, and 10. Calcium dependent factors. What other pathway? Vitamin K, right? So that's where our vitamin K antagonists actually act, because those are our vitamin K dependent factors, which are made in the
Liver.
The liver. Who said the liver? Yes. So they are made in the liver, but vitamin K is actually produced in the
But the gut.
In the gut, right? The small intestine.
All back here.
That's the entire back there. Yeah, yell it out. I'm getting quick at the ball back there. All right, so most of the vitamin K that is active in the body, KH2, is produced in the intestine. Okay, a small amount of the vitamin K, KH1, is taken in by the mouth, orally, right, through food. But most of our vitamin K is actually made in the intestine by what process? Mouth. Vitamin K synthesis is by what? Yes, the gut flora or the bacteria. So the gut flora or bacteria is produced by what? Antibiotics or some other state, right, where the patient, for whatever reason, is losing losing their gut flora, so maybe severe illness, right? Because gut flora stays populated when we eat and have normal gut health, right? When we stop eating, our gut atrophies, our gut flora changes when we're on chronic antibiotics, things like that, right? Okay, but most of the vitamin K we're getting is actually not taken in from the diet. Okay, most of it's from the gut bacteria. So take your probiotics, make your kombucha.
Yeah.
All right, so what is a NOAC?
No, wait, don't. No.
Damn, she threw that. She about to off my head with it.
Novel oral anticoagulant.
I agree.
Got it. What do you say?
Novel oral anticoagulant.
Good.
You said novel? Novel.
Novel oral anticoagulant. Novel means new, right? Oral anticoagulant. Because prior to this, the only oral anticoagulant that we really had to use was, which is rat poison. All right. So what is one drawback to using NOACs? We just talked about this a little bit. Whoa! She's like, this is like your anxiety provoking class. So what are some drawbacks to using NOACs? So there is no monitoring parameter, which is in some ways a good thing, right? So it's more cost effective because the patients don't have to go and get their INR checked every couple weeks, right? So, you know, the studies that have been done have shown that this particular dose that we give keeps people at a level which is has efficacy against prevents clots forming or prevents clots from worsening, right? So at this particular dose, we have found in the clinical trials, based off of the populations that we've studied, that as long as we're not using these patients in renal failure or patients that have a BMI above 40, we are consistently inhibiting clotting factors and having the outcome that we want in most patients by using that same dose with no monitoring. So there's a benefit to that, right? But also, if we have a patient and we're not sure if they're maybe on too much of the drug, there's no way for us to really check, right? Other than getting a drug level, which is pretty hard to do. Most labs don't just run like a random drug level unless it's a drug that we generally monitor, like something like dilantin, which is an anti-epileptic, or certain other drugs that we have to monitor levels. But can't just get like at the bigatran level, okay? All right, so that's one issue. What else?
Does it have any
No antidote.
Up until recently, there was no antidote. We now have an antidote for both the bigatran and the 10A inhibitor, so that's good. Yes?
Does it have anything to do with it being oral? And like if it has to go through this whole like first pass metabolism?
So, meaning you're saying like
let's say if you
that's why
start,
we can't
if you start
monitor
with
it,
10, your body's not gonna use up 10 because some of that 10, for lack of better words, is already eaten up by the like liver and stuff like that.
Well, sure. I mean, so certainly if the patient has other factors that could inhibit oral absorption of the drug. Oh, it must be 1:30. I'm supposed to take a break at 1:30.
Yeah.
All right, we're taking a quick little break. 5 minutes. No. Come on. They just got into it, and now you're making us. Just kidding. Come on in. All right, 5-minute break. We're talking about anticoagulants. All right, you guys go take a break.
This is for what drug? For what drug?
No wax. Yeah. A lot of older individuals, elderly patients have comorbid conditions, right? And renal failure tends to be one of those things. Not in everyone, but in a lot of patients, their renal function declines. Okay. So what's exciting is that this past year, just in May, in 2018, an antidote got approved by the FDA for the 10A inhibitors, which are a whole nother class outside of the bigatran. Our 10A inhibitors, our other NOACs, right? So there's really 5 drugs that we use for NOACs, which we're going to go over. But there's an antidote that was approved. Unfortunately, it's still pretty hard to get. It's very costly. Not every hospital has it. But we now have the ability to reverse all NOAC drugs if we have access to this antidote. All right. So we talked last week about endothelial injury and platelet plug formation, and we're all experts in that area now. Yeah? Yeah. So now today we're going to talk about the coagulation cascade and propagation of the clotting cascade, which is also another very important part of clotting. We're then later today going to talk about termination of clotting by antithrombotic control mechanisms and removal of clot by fibrinolysis. So this is the clotting cascade. Know it fairly well. Know at least knowing where the cascade comes together, the intrinsic, which factors are involved in intrinsic versus extrinsic, and then the common pathway, and know kind of where the drugs are inhibiting and what we're using for monitoring in each case, depending on what's inhibited. So there's 13 factors. There's the inactive form and the active form. The active form is symbolized by that little a, right? So there's oftentimes other factors or calcium dependence that is required to make a factor go from inactive to active, or some kind of enzyme or serine protease that actually takes that drug or that factor from the inactive to an active form. As we know, some steps are calcium dependent. They are the same as the vitamin K dependent factors 2, 7, 9, and 10. Factor 10 is where both pathways come together to form the common pathway. Okay, so looking back here, I have this slide multiple times in the lecture so that rather than trying to go back to that slide, that you have that slide popping up all the time to refer back to as you need to along the way. So the intrinsic pathway, right, is actually initiated by surface contact, so vessel injury or trauma occurring. That's the surface contact. The factors that are involved are 8 through 12, but in order, 12, 11, 9, 8, and 10. Factor 8 and 12 are very important in that cascade, and they are measured by which test? The PTT. So intrinsic pathway is measured by the PTT here. The extrinsic pathway is stimulated by everything. Okay, so yes, injury will stimulate that as well, but so will the patient being sick, hypoxia, sepsis, infection, and that is initiated by factor 3, which is also called tissue factor or thromboblastin. The factors that are involved there are tissue factor or factor 3 with 7 in combination, activated 7, and 10. We measure the extrinsic pathway using the PT-INR. Okay, really important to know that. The common pathway is really thrombin and fibrin, right? Fibrinogen to fibrin. The thrombin then stimulates this feedback loop. So we talked about this a little bit last week, that once thrombin is activated, it goes back and stimulates other factors to continue to be produced to keep that clotting going. Right? Particularly factors 5 and 8 are some of the factors that are very instrumental in that feedback loop. So thrombin is stimulating other factors as well, but 5 and 8 are predominantly what is stimulated. Both PTT and INR measure the effectiveness of this pathway, but you can also use thrombin time to measure that, okay? So it's very non-specific. So having abnormalities in these clotting factors, especially when you don't know what's going on with the patient, it can be a little bit difficult to find out what factor is the problem. Is it several factors? Is it one factor, right? But the common pathway, if there's a problem in the common pathway, all of these numbers are going to be abnormal. And are they going to be high or low? On what?
Whether it's excessive clotting or the opposite.
Okay, so if you have bleeding, what would you expect? All of your numbers to be high or low? Can you explain that to me? Okay, so but when you say high or low, what are we measuring? So when we talk about the PTT, but what? Time until the clot forms. So the higher it is, the longer it takes. The longer it takes, the less clotting factors, right? So if you're bleeding and the problem is with the clotting factors, right? So let's say that you have a problem with factor 7 in particular, right? We said factor 7 is predominantly from what part of the clotting cascade? Extrinsic. Extrinsic is measured by PT-INR, right? So the higher the PT-INR, the less factor 7 that we have, probably, right? That's right, so it's taking longer to clot. So if your PTT or INR are elevated, that means our ability to clot is less, right? So there's a problem with one of the factors. generally speaking. Okay? All right. You guys got that? So if the PT-INR is low, right, it doesn't necessarily mean that the clotting factors, there's too many clotting factors, right? Because we expect that there's a normal range, right? And so we expect that, you know, that there should, your PT-INR is never going to be 0, right? There's always going to be some clotting and some coagulation happening in the body, right? But there's really no level that's going to be, like, we don't have like a low level of normal, right? So if somebody's in a hypercoagulable state, generally we don't see that the INR and PTT are low, which is not really something that we generally see, even if there's one factor that may be abnormal. Even if we're, you know what I mean? Does that make sense?
Yeah.
Okay. All right. So remember, intrinsic is monitored by PTT, extrinsic is monitored by PT-INR, and then the common pathways, both PT, PTT, and thrombin time. Okay? So all of those are able to monitor the efficacy of each. Now know that this is not perfect, right? So there's certain factors that have more of an involvement in the clotting cascade than others. And for that reason, like PT-INR, factor 7 is very, very important, the activity of factor 7 in PT-INR. Okay, and so the activity of factor 7 really changes the PT-INR a lot, more so than, let's say, tissue factor. Okay, but there's other factors that PT-INR is actually looking at. It's not just factor 7. It's just that that factor generally tends to have the most influence over the test. All right, so let's see here. What do we got? Thank you for letting me know.
So.
Thanks for your physical support. He's like, I don't know how to do anything, but I'll stand here. I appreciated that.
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor 7. Finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the two pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A in combination with 5A activates thrombin and induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot. It can be concluded that the central role of factor Xa in the coagulation cascade makes it a viable target for therapeutic intervention in pathologically altered blood coagulation.
Okay. Got it? All right, so just a reminder here where the calcium dependence is in the cascade, remember that. So we talked a little bit last week about some of the antithrombotic control mechanisms that there are, right? And we talked about the ones that are inside the vessel, right, endothelial, or that are released from the endothelial surface when it's actually damaged. So some of those, right, we talked about prostacyclins, ADPase, and nitric oxide. So how do those have their action, generally speaking? Jennifer.
I'm sorry, the question,
How do those factors, right, specifically the endothelial ones that we talked about last week, how do they have their action to help clotting to cease?
isn't it like a receptor in the?
One of them is, so which one is that blocks the receptor?
ADA?
Good, so what receptor does it block?
G2Y1 and G2Y12.
G2Y or P?
P2Y.
Yes, okay, good. So P2Y12 and P2Y1, so it blocks the ability for ADP to act as an agonist there, right, and activate the platelet. Okay, good, so we're inhibiting platelet activation. What else? What about our prostacyclins and our nitric oxide, Bradley?
Prostacyclins and nitric oxide, like what do they do?
What do they do?
Vasodilate.
Very good. So they vasodilate the vessel, right? So vasoconstriction happens when we get an injury, and that actually helps platelet aggregation, right? But vasodilation actually prevents that process from happening. So those are some of the things that are naturally built into our body to actually be these antithrombotic control mechanisms, meaning that doesn't allow the body to make too many clots, right? So the other ones that we haven't talked about yet are factor inhibitors. So the factor inhibitors, when we talk about factors, we're talking about the coagulation cascade. So we briefly talked about antithrombin, which used to be called antithrombin 3. That gets inhibited, we know, or actually gets activated, right, by heparin. So, and I'll talk to you guys about that a little bit. So it gets activated, antithrombin, right? It makes it so that thrombin is not able to work normally, right? And so normally in the body, it's kind of hanging around and doing its job, but just, you know, mediocre, making sure everything's okay. But when you add heparin to the mix, it's like putting it on speed, right? It's like really giving the antithrombin the power to say, like, we don't want to make any more clots, okay? And so we're actually able to activate antithrombin by using heparin products even more than its natural mechanism in the body. But it's always in the body. And a lot of these things that we're talking about, right, are in the body happening all the time. It's just we have the ability to make it happen more or give it exogenously, right, to change the way that it's happening in the body to our liking, right, based off of what's happening with the patient clinically. All right? We actually use things like nitric oxide in patients that are in severe respiratory distress in the ICU to try to cause more vasodilation in the pulmonary tree sometimes, if pulmonary hypertension is an issue. So we actually have created drugs based off of the natural things that happen in the body, these natural factors or proteins that are happening in the body that we learn the effect of and then can use to our advantage to actually help our patients. Tissue factor pathway inhibitor, or TFPI, and the protein CNS pathway are all factor inhibitors, and we'll talk about why. So protein CNS, we briefly touched on it in lab the other day, and then I realized you had no idea what I was talking about, so I stopped talking about it. So protein C and S are actually also made similar to factor 2, 7, 9, and 10 in the liver. Very good. So protein C and S are vitamin K dependent factors that are made in the liver. However, unlike 2, 7, 9, and 10 that are procoagulant molecules, these are anticoagulant molecules. So there has to be some way to tell the clotting cascade to stop. Because if we didn't, we just have clots everywhere. Right? So think about all the processes in the body always have this homeostatic balance, right? Where if it tells the body to do something, there has to be a stop mechanism to say, okay, enough is enough, you did your job, now it's time to actually break the clot down, right? Or stop the clot from continuing to propagate and form. Otherwise, we would result in a lot of tissue ischemia, right, to major organs. So this is one of those functions. And now know that this is not the only one, right? Because we just talked about antithrombin, we talked about TFPI, this is another. That's important to understand the mechanism for what we're going to talk about. So protein C and S actually inhibit the ability for thrombin to work by binding to thrombomodulin. Protein C gets activated to activate the protein C, which stimulates protein S to then inhibit factor 5 and factor 8. By inhibiting factor 5 and 8 and making them inactive, we're really inhibiting the ability for thrombin to do its thing and for that clot to continue to propagate. So this is protein C and S are really important in order to stop or regulate the clotting process. Okay? All right. So first we're going to talk about vitamin K dependent anticoagulants. And the one that we're going to talk about is the only one that there is, which is warfarin or coumadin.
I have a question on the last one.
Yes.
For protein S, is it just like hanging out?
It is getting stimulated by activated protein C. But yes, it is hanging out. Now, when we have a clot, the amount of protein S actually, when we have an active clot, generally the amount of circulating protein S actually gets consumed and is actually quite low. But generally, yes, it's just hanging out. There's a level of protein S that is active in the body all the time, waiting for protein C to become activated so that protein S can then do its job. What?
So does the thrombomodulin activate protein?
Yes. Yep. Well, the combination of thrombin binding to thrombomodulin activates protein C. Yep. Yep. Okay. So warfarin. So warfarin, the name warfarin came from where it was discovered, which was the Wisconsin Alumni Research Foundation. And it's kind of sad the way that this was discovered. So there was basically these cows were eating this grass, which actually was spoiled sweet clover, and they were dying. And they were trying to figure out what was going on, and they realized that they were eating this grass, this sweet clover that had been spoiled, and contained within that was this stuff called bis-hydroxycoumarin, which is an anticoagulant. So they realized, like, okay, well, if the cows are dying, basically hemorrhaging, then we could take whatever they're eating and create a synthetic form of it, and we could actually help people that are having too much clotting. And so that's exactly what they did. They made a synthetic derivative of this called dicumarol, which is warfarin. And this was actually done way back when in the 50s. So this was the first oral anticoagulant that was approved. Initially, before it was actually approved to be used in humans, it was used to poison rats, basically to cause hemorrhagic disease. And we still use it in rat and mouse poison. Right? That's how we poison them, is we actually give them a toxic dose of this agent that causes them to hemorrhage to death. And that's how we kill rodents. So just know that next time you put that rat trap out, think a little bit about whether you really want to do it. And that's why when our pets actually get into, like a rat or mouse trap, it's really dangerous for them because they're consuming the same thing, right? So depending on how large or small the animal is, it could really be toxic and could potentially kill them because we're basically giving them a toxic dose of warfarin. So this was really the only anticoagulant that was used for a long, long, long time. And when I was first a PA, which is, 10 years ago, which is a long time ago, but really not that long ago, we didn't have any other oral anticoagulants. So I lived in the era not that long ago where there was no NOACs. That wasn't even a thing. And so it's kind of cool to now see how many anticoagulants. Okay, my screen is still the YouTube screen here. There we go. Okay. So we already know the mechanism of action, but I just want to be a little bit more specific about it. So we're not actually actually, unlike the NOACs or unlike the heparins, we're not actually binding directly to the clotting factor itself. All we're doing is reducing the ability of the clotting factor to actually be produced and be in circulation, right? So we're inhibiting the vitamin K enzyme, and that then does not allow the liver to produce those factors, including protein CNS. Okay, so this is the pathway here. And where we're actually inhibiting is here. So we're inhibiting the ability for vitamin K epoxide reductase to then convert vitamin K into the active factors. Now, this is really specific for vitamin KH2. I said that vitamin KH2 was the vitamin K produced where? In the gut, which is most of the vitamin K. Keep in mind, vitamin KH1 is taken in through our diet, which is why diet is important in patients that are on Coumadin therapy. And we'll get to that in a second. Okay, so just know that we're actually inhibiting the ability for those factors to be formed by inhibiting the enzyme vitamin K epoxide reductase, which then does not allow vitamin K to then go on to help in the production of producing 2, 7, 9, and 10. But we're also inhibiting our antithrombotic mechanism, right? Protein CNS. So when we give warfarin or Coumadin, we're also inhibiting protein CNS. Okay? All right. So what do we use it for? We use it for primary prevention, meaning in a patient that we know has a high risk of the disease, we use it to try to prevent that from happening. So to try to prevent embolic stroke and paroxysmal atrial fibrillation in mechanical valves. For secondary prevention, for a patient that's already had a stroke or MI, we really don't use it much for MI as much as we use antiplatelets, right? So it can be used, but really less commonly in MI unless there's some reason a patient can't be on an antiplatelet. And then for secondary prevention of venous thromboembolism. So generally, once a patient has had several thromboses, they go on lifelong anticoagulation, okay? So once you've had a thrombus, and that thrombus either propagates further, gets larger, or they have a recurrent thrombus, they need to be on lifelong anticoagulation. And warfarin may be one of those things. Warfarin, because it's so old and it's literally rat poison, it's been around since the 50s, it's like almost free. Versus like a prescription, let's say for something like a NOAC, like dabigatran or rivaroxaban. Those drugs are probably going to be tier 3 for patients that maybe have failed other anticoagulants, or for patients that say, let's say, also have a co-occurring malignancy. Those patients where it hasn't been well studied, then the insurance company may pay for it. But a lot of times we're like having to fight with insurance companies to pay for this, to pay for other drugs, because warfarin is still considered to be standard of care. All right, so how do we take it? We take it orally. Generally, we start patients at 5 milligrams a day. The absorption is absorbed in the gut. It's the absorption actually is rapid, but the half-life is about 40 hours. So it does require metabolism by the CYP450 system, and 40 hours for a half-life is pretty long, right? So when you guys see a half-life of 40 hours, what does that tell you? Okay, so it stays in the body for a while. How about you, Marianne? What does it tell you?
That's what I said.
What else?
If it stays in the body for a long time, that means it's going to have a lower clearance.
So it'll take longer to clear it.
Right.
But what about, so when we think about like the drug being at steady state, how many half-lives does it generally take for a drug to get to steady state?
Oh, 5.
Okay,
Yeah.
5. So if a drug takes 5 half-lives to get to steady state, somebody do the math. How many days is that?
Over a week.
A lot of days, right? Okay, so if that drug takes 5 half-lives to get to steady state, when we make an adjustment in that drug, we're not going to see the peak effect for about 7 days. That's a long time to wait for people that love instant satisfaction. You want to make a change, you want to check the INR the next day, you want to see that it went up. But if you made a change in someone's drug dose today, and you saw the INR went up tomorrow, you should probably be a little worried. Because if it's already going up today, means that's a reflection of probably what happened a couple days ago. Not a reflection of what you just did yesterday, because you're not going to see that, right, for 7 days, really, that full effect of that drug, okay? So getting an INR level on a patient every single day is probably not really helpful, right? When you made a change, you should really wait 5 to 7 days before you get another level. Does everyone understand that? Otherwise, you're wasting money. Yes?
I thought you could give warfarin intravenously, no? Oh, okay.
Okay. So there's a dose-response relationship, which is very variable depending on certain factors. So some people can be more sensitive or more resistant to the drug. That's what this means, right? Dose-dependent variability. And that depends on, and this is some of the problems you get with the drug. So age, weight, liver disease, dietary vitamin K1 intake, keep that in your mind. Genetic factors, right? CYP450 enzyme factors. Concomitant use of other drugs. Why would that be an issue? Drug-drug interactions. When we say drug-drug interactions, generally what are we talking about? How? Not necessarily. So certainly having people on, like, yes, you wouldn't want to necessarily have somebody on a 10A inhibitor that's also on warfarin, right? Okay, but
Because some drugs will make the level of warfarin higher.
how? How is it metabolized?
The proteins?
CYP.
Certain
In the liver?
Okay, so certain medications can be CYP450 inhibitors or inducers. And that's important because it's going to change the way that your drug, other drug, is metabolized. You guys really need to understand that concept, okay? So if you have a CYP450 inducer, what's going to happen? So faster metabolism of the drug, right? So lower drug therapeutic levels. Versus if you have a CYP450 inhibitor, right, that's not allowing that drug to be metabolized, you're going to have more of that drug. Now, the question is that drug in its active form or inactive form? This drug is in its active form. It's metabolized, but it's the initial form of the drug is active. It's not a prodrug. Versus a prodrug, right, that has to get metabolized to its active form. All drugs are metabolized. But some drugs are metabolized from an active form to another active form. Some drugs are metabolized from an inactive form to an active form, right? And so those are the drugs, right, that in its inactive form are going to have no effect. But this drug, right, this is its active form. And yes, it's metabolized, but it has active metabolites, but its initial form is also active. Do you guys understand that concept of why that's important to understand for a drug? Okay. All right, so compliance is an issue, right? So if a patient misses a dose of the drug, when do you think, Duyen, that you're going to see, ready? Nice. When do you think that you're going to see the change of the dose? Like you're going to see the change in the INR level? If I missed it, I'm on warfarin. I missed a dose today. My INR level should be 2 to 3. Now, when would you expect that you're going to see the effect of that missed dose?
3 days later?
Yeah, so 3 to 5 days, maybe closer to 5 days later, right? Based off of the half-life of the drug being 40 hours. Good. And obviously it depends how many doses I've had, right? Have I been on the drug for years and I missed 1 dose? Or have I been on the drug for a day and I missed a dose, right? So that's going to be, if I'm already at steady state and I miss 1 day, it's going to affect me a little less than if I'm just getting on the drug, right? And I'm not even at steady state yet. All right. And then dose adjustments, as I mentioned. So this drug is a category X in pregnancy. Stanley, what does that mean?
I mean, you don't give it to pregnant women?
Do not use, not safe, teratogenic, causes birth defects. Don't use it ever, 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 ever. Okay? So what drug can be safely used in pregnancy? What anticoagulation? There's really only one. Heparin, yes. It's really the only anticoagulant that is safe in pregnancy to use as of right now. Part of that may be because we haven't fully studied the anti-10A inhibitors and dabigatran in pregnant patients. But as of right now, it's the only drug. Heparin is the only drug that can be used safely in pregnant patients. All right. So one of the major things that we talk about is how then do you dose warfarin? We start out generally with 5 milligrams a day, unless our patient is let's say very old, very small, then you think that we want to start out with less or more, Christian? Good, so small, elderly, frail. Maybe we're going to start out, like we know they have liver disease, right? We're going to maybe start out with a smaller dose than we would if our patient is young, healthy, robust, like one of you guys. I'll give you 5. Okay? All right. So, a few days after we initiate warfarin, we check an INR level, a PT INR level. What do we want the PT INR level to be, Bradley?
2 to 3.
Okay. So what do we do if it's not 2 to 3 after 2 to 3 days?
Adjust the dose.
Increase the dose, but we want to increase it little by little, right? So the problem becomes when our patient is on the medication for a primary indication versus a secondary indication. If our patient actively has a clot, we want to get them anticoagulated immediately. We don't want to be like, well, let's just wait for a half-life of 40 hours, 5 to 7 days for you to be fully anticoagulated. That's a problem, right? So for secondary prevention in patients that have had a stroke or MI previously that you want to put on warfarin, that's a little bit less of an issue. Or for someone that we're trying to prevent embolic stroke in someone with paroxysmal AFib, well, their risk of stroke today is the same as it was yesterday, the day before. We could probably wait 5 to 7 days to get them therapeutic. Versus if I have a pulmonary embolus right now, I need to be anticoagulated right now, right? To not allow that clot to keep forming and forming and forming. Warfarin is not a good drug for that because it takes so long to actually have its effect, right? And the half-life is so long. So we're going to slowly monitor every 2 to 3 days, some might say 3 to 5 days, to get to your target level of 2 to 3, and we're going to increase. Now, if the INR is above 2 to 3, generally we need to hold the dose of the medication and decrease the dose of the medication that the patient's getting daily. So it's a little bit of a skill to be able to dose warfarin. There is no great algorithm to say exactly what to do. A lot of it is based off of your experience, right? And so sometimes we under or overshoot, but that's another reason why it's not a great drug, because it's really difficult, especially because all of this stuff factors in. So tell me about dietary K1 intake.
The more vitamin K you get, the less warfarin potency.
Right, so vitamin K1, right, does the same thing as vitamin KH2, which is stimulate factors 2, 7, 9, and 10 to produce. Vitamin K1 is not sensitive to the induction of the vitamin K reductase pathway. So vitamin K1 actually is still able to produce factors 2, 7, 9, and 10 even when you're on warfarin. Now you would have to eat a massive amount of vitamin K1, right, to really make an impact on your INR. Because we know that vitamin KH1 has a less impact than vitamin KH2, because it's just about 80% of it is made in the gut, and then just a small percent is what we eat, right? And like most of us don't eat enough vitamin K to actually change our levels of factors 2, 7, 9, and 10. But what has a lot of vitamin K in it?
Banana.
A lot of green leafy vegetables. Okay, so yes, broccoli, kale, I'm sure that avocado has some too, but green vegetables, especially green leafy vegetables, have a lot of vitamin K. So we should tell our patients, right, to just not eat any leafy green vegetables when they are on warfarin. Yeah. No. Ashton said no. Tell us what would be your recommendation as the dietitian of the class? Eat consistently. Good. Does that make sense to everybody?
What did she say?
Say it louder.
Be consistent with how much vitamin K you're
Be consistent. So if I'm eating this much vitamin K today, I should eat the same amount approximately tomorrow. And I don't have to count the spinach leaves, okay? But if I'm eating a salad a day, eat a salad a day. If I'm eating 2 salads a day, just keep it regular. What you don't want to do is be like, I'm going on a spinach diet today, and then I'm going on a keto diet tomorrow, and then a spinach diet the next week, right? Because that's going to make your INR levels go all over the place. Just keep it consistent. So never, ever, ever tell your patients, and you will still hear practitioners tell their patients, right? Don't eat any green leafy vegetables, you're on warfarin. It's not right, right? So we don't want to take away anything that our patients are eating. We just want them to keep it consistent. That way, those levels will stay the same. And then that way you know how to dose the warfarin accordingly. Generally at the beginning, we have a really hard time getting people stable. But then once we get their, lifestyle patterns down, you usually get on a consistent dose, and then you only have to monitor the INR monthly. Okay? But generally things that change. So can you think of anything else that might happen to a patient that would change their INR levels? If they've been on a consistent dose of warfarin for years and years and years, their INR is always 2.4, and now what could happen to them that would say, you know what, Chrissy needs to check another INR level sooner than she would normally?
If she has a clot or something.
If she has a clot, okay, so if you want to make sure, maybe there's more factors being consumed or produced that is going to change the level, is that what do you think an acute clot would? So if she has an acute clot, why would you want to check an INR level right now? Good, so did her INR drop for some reason, and what could some of those reasons be? Good, so if she's on antibiotics for an infection, right? So that's going to change the amount of vitamin K that's being produced in the gut. Also, what else could it be? What else could it do? Antibiotics are often an example of what? Enzyme inducers or inhibitors, right? So know which antibiotics your patients are on. Is it going to change the way that the drug is metabolized? Because if it is, it's going to change the INR level. Good, so infection. What else? Any drug change. You need to be aware of any drug change, right? So any drug that patient could be on that could be an inducer or an inhibitor, you need to know about it. Is it going to make the INR go up or down? You are negligent as a provider if you put your patient on a drug that is, let's say, a CYP inhibitor, and that INR goes up and that patient bleeds to death. You're reliable for that. Responsible for that, I mean, because it's your job to know the interactions of the drugs, right? So if you put the patient on a drug that changes another drug that you give the patient, and they have an adverse outcome, it's your fault, right? So important to know this stuff, and I'm not trying to scare you guys, but it's so important, right? So check, so how would you check to remind yourself? Because nobody expects that this pharmacology class is going to teach you everything you need to know, and you're going to just know, now I've memorized all the CYP 450 inhibitors and inducers, and I'll never make a mistake. So you check the drug indices every time. You do interaction checker. You look up the drug. You look at how it's metabolized. You look in clinical key or Epocrates or micromedics. Make sure you always do your interaction checkers for the drugs like this, that a patient, if their INR went from 5 to 10 and they had a massive GI bleed and died, that'd be horrible, right? So know if your drugs that you're putting your patient on, or other providers are putting your patients on drugs that you don't know about. Serious, serious, serious thing. So get a good medication list. Definitely ask your patient any new medications you're on, right? Any recent antibiotics, know it. Okay. What else?
Question.
Yes.
In an Hispanic, very common people just here, take this antibiotic for that, take this other antibiotic for that. So people come to you at their office and they tell you, oh, I'm this and this. You give them more food. But they take the antibiotic on their own. And they end up in the emergency room. It follows up to you. How's that gonna? It's gonna make you look bad. It's gonna make you look like you.
That's a great question. So what do you think? You're the provider.
Wait, what was
You're
this
going to be taking care of the
question?
population.
I documented it. I asked the question.
Right.
What drugs did you take? You said none. Or
Right.
whatever drugs that were not.
Documentation is so important. So the question was, did you not hear the question?
We
No,
heard
we
like bits and
didn't.
pieces of
Okay,
it.
so he said, in the Hispanic population, it's not just the Hispanic population, but this is a good example. Oftentimes patients will self-prescribe, or let's say they also go to Tijuana regularly. You can get medications much more available, right? So there is no, you don't need a prescription to get antibiotics. You can just go over the border and get the medicines that you want and then come back. So if patients are self-prescribing things like antibiotics, or maybe sharing drugs amongst people, and your patient is on warfarin, and they took an antibiotic from another person, and they had an adverse event, they bled, and they end up in the emergency room, and it's your patient, how does that look on you, and what are your responsibilities in that situation? Okay. So what did you, and then you said a very great answer, which was, what were your responsibilities in that situation? Documentation, 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 but even more important than CYA, right, by documenting, so cover your ass. You know what that means. So even more important than documentation, the documentation is important for you. But what's even more important? Patient education. Letting them know, I'm putting you on this drug. A, is there a drug that would be better suited for them? Could we get them on a drug that would be better for them if we know this is a practice that they generally, like we've advised them about, they still keep doing it? So educate, 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 right? I'm putting you on this medication. It's really important for you to understand the side effects. This is what could happen, and if you do this, and I've documented in my note, patient requires this anticoagulation. Insurance will not cover alternative anticoagulations. I have discussed the risks associated with X, Y, Z. I have advised the patient that if they have any bleeding in their urine, stool, epistaxis, headaches, you know, they go to the emergency room immediately, right? So you're not only educating the patient, but then documenting that I have had this conversation with them, right? And then it's just continuous education of that patient. When they come to your office and they tell you, oh yeah, I took these antibiotics, gently reminding you, this is a possible complication of that, right? Not being just frustrated, oh, they never listen to me, ugh, right? But rather, you know what, just realizing, okay, this is just a battle that we're gonna have to keep fighting, and they may or may not necessarily get it on the first time around, but I'm gonna keep trying to educate them patiently, and if I can switch them off that drug, I will. Right? So we want to always try to put our patients on the least risky option. Yes?
Are there other like common medications that people with warfarin should avoid besides antibiotics?
So Professor Mooney is going to go through an entire lecture basically about especially OTC herbal medications. There's a ton of interactions with warfarin. So you guys will have a whole lecture on that. Yeah. And I have a list as well for you. So you guys will get my whole slide set like last week as well. But there's hundreds.
Okay.
So yeah, your patient should be aware of that. You should even give them a printout, right? And say, you know, these are the interactions. You need to tell me if you're on any of these herbal supplements, Chinese medicine, over-the-counter medication, and prescription medications. Yeah. So this is a list. All right, and this is just a minimal list, but lots of antibiotics up there. Lots of foods, herbal products, green tea, ginseng, St. John's wort, coenzyme Q, vitamin E, ginkgo biloba, garlic. Tons. Yes. So especially garlic in supplementation. Right, so garlic in food, the amount of garlic you're eating, but a lot of people take garlic as a nutritional supplement.
Especially in Africa, they just be chewing garlic.
Yeah, yes.
Is it because, like, I know I looked at garlic and it helps with like vasodilation because it helps boost NO. So is that one of the reasons why, like, you don't want to have like anything that helps with vasodilation?
Most of these drugs actually interact with CYP 450. So I will give you guys a link. I just went to the Society of Integrative Oncology conference this weekend, and one of the lectures was on herbal supplementation. And so most of the drugs and most of the herbs in vitro activity have really had a lot of activity on the CYP 450 system. Now, studied in humans, we actually have not been able to recreate those same interactions because of the bioavailability of the drug actually tends to be pretty poor when taken orally. However, in studies that we've done in animal models, it has shown a lot of CYP 450 inhibition and induction. So that's like predominantly why.
So like, you know, there's like lots of herbs you take, like ginkgo, like I take ginkgo, and you know, it has to go through CYP 450. Now, is that taxing on your liver still, even though it's like a natural herb, compared to if you take a drug like warfarin?
Depends on how much that you're taking, right? Because not all supplements are created equal.
Yeah.
Also, although supplementation is regulated by the FDA, it's not regulated nearly as much as what's regulated or what prescription drugs are regulated by, right? So a lot of supplements you buy on Amazon or whatever are adulterated with other substances, some of which are prescription drugs, actually, that come from other countries. The other thing you need to be able to be careful, that you need to be mindful and careful of, is the labeling. So whether something is actually an extract or something is actually pure product. Because what has actually been studied in clinical trials, right, versus what you're actually getting in that capsule can be wildly different. So we did this exercise where this patient comes in with a natural product that she gets on Amazon for hot flash relief. And she says, is this okay for me to take? And there's 4 different things in it, right? And one of the things, it just says that it's licorice root 150 milligrams. So licorice root has been studied in many different studies. The upper limit of normal of the amount of licorice root that you can take, I think, is up to like a gram a day or something. But licorice root has properties in it that can actually cause sodium retention and potassium excretion. And so it can actually cause hypertension and severe hypokalemia. And so this product, right, on the label, it actually did not say the amount of licorice root because that's an extracted product. So you actually have to have the ratio of what the extract is. Is it 2 grams to every 1 mil? Or is it 5 grams to every 1 mil? Or 50 grams to every 1 mil? So you have to really know what you're taking. So the answer to that question is I don't know. Because I would have to actually see the supplement and see like, well, how much ginkgo are you actually taking? Is that a safe dose? Has that dose been studied? What are the properties associated with that particular dose of drug? Yeah. And like I said, a lot of this stuff has not been studied in human controls. So all the data we have is based off of animal models, which we know is not the same, right? Because a lot of the supplements that we take are actually not well absorbed into our bodies. So when they do pharmacokinetics, the dose that that the mice were getting is very different than what we're actually seeing in the human. We're seeing a lot lower levels, right? So you could be taking like 5 grams of turmeric a day, but actually the amount of turmeric that's actually in your body, because it's not very bioavailable, is very low. Okay, so a lot of antibiotics on here, a lot of proton pump inhibitors, anti-epileptic drugs, some cardiac meds. So things to watch out for. So alcohol, because patients that drink alcohol often frequently have liver disease. Tylenol, anabolic steroids, H2 blockers, proton pump inhibitors, diflucan, which is an antifungal, erythromycin, ciprofloxacin, isoniazid, all antimicrobial drugs, Flagyl or metronidazole, which is also an antimicrobial. So a lot of drugs that are commonly used, right, in our culture. And so we have to make sure that we know if our patients are on these drugs so that we know how to adjust their warfarin appropriately. So these drugs here increase potency of warfarin. So that means they are probably CYP. So they increase the potency. So they're inhibitors, right? So inducers actually increase the activity of the enzyme. Increasing the activity of the enzyme increases the metabolism of the drug and decreases the level of the drug. Okay, you guys aren't getting that. Are you getting it now?
Yeah.
Okay, so you gotta think it through. Yes. So if you have something that increases the potency, increasing the potency means the level of the drug is higher, right? So if the drug is higher, it means that it's not being metabolized normally. Something is inhibiting the ability for that drug to go through normal CYP 450 metabolism. So the level of the drug is higher, okay? Now if we give an inducer, meaning it causes those enzymes to more rapidly metabolize the drug, we're going to have lower levels of the drug if we test. Okay? Does everyone understand that? Everyone's clear? Affirmative. Awesome. Okay. So, moral of the story. I don't ever want to hear you guys telling your patient not to eat broccoli, kale, and lettuce. Just tell them, God, she's already out of class. Alright guys. Alright, so yes, consistency is important. So monitoring, know this, know this, know this. Guys, seriously, if you guys get to my hematology class next semester and you're still confusing monitoring of cumin and heparin, I'm going to be personally insulted. Okay? So know this. If nothing else, please know everything. But if nothing else, know monitoring of warfarin is PT. Monitoring of heparin, I'm going to tell you how to remember this, and this is not a good way to know this because it's memorization, but I'm going to tell you how to remember it. Okay. PTT The TT looks like an H. TTT is heparin. The other one is Coumadin. Okay. So for most people, our target's 2 to 3. For prosthetic valves, 2.5 to 3.5. Like I said, measure the first INR after a few days because the half-life is long. Steady state takes a while to get to. And if they don't have an increase, just be mindful when you're increasing the dose because you know that several days later, if you increase it too quickly, right? So if I increase by 2.5 milligrams today, 5 tomorrow, 7.5 tomorrow, because they're still not at the dose now, 4 days later, now they're overshooting their target, right? So increase little by little, be patient as you're waiting for that increase. Yes?
So you have a patient on warfarin, they need an antibiotic, so you can't just like not give it to them because they need it, right?
Right.
So, but that antibiotic is like an inhibitor of the CYP450.
Okay.
How would you?
You tell me.
So you have to wait a few days, like, because you have to adjust the dose of warfarin, but then that would take a few days for it to have an effect, right? So they would have to wait 3 to 5 days to take their antibiotic?
No.
No?
No, so if you, okay, so the drug that's in the system right now, right, is already at a steady state, right? So let's say our drug's at steady state, right, we're already here. We need to give antibiotics. That's a CYP450 inhibitor, you said? All right, so what are you worried about? That the drug level is gonna go, so if this is the drug, this is the level, what are you worried is gonna happen? This is the level of the drug, everyone. It's gonna go up. So we're worried that it's gonna go like this, right? So our time point is here. How long do you want your patient to be on the antibiotic? What do they have?
7 days.
7 days.
Yeah.
All right, so let's say this is day 1, this is day 7. So we know that there's a steady state of the drug. It's constantly being metabolized, right? And we're going to give something that's going to change the metabolism of the drug. So what should you do to accommodate for that? Good, so what would you do? Good, so if you know that this drug is going to increase the level of the warfarin, starting today, right? And you're going to have them on 7 for 7 days. If they're on 5 milligrams of Coumadin, what would you recommend doing, Stephanie? Great, decrease it by 2.5. And then when would you check an INR, Kate?
In 3 to 4 hours.
Sure, 3 days.
Yeah.
Great, perfect. Yeah, 4 days. Yeah, great, perfect. You guys see, you don't even need me. All right, good job. Now, could you have overdone it and decreased too much? Maybe. But would you rather that, or would you rather that their INR's 10 and they're bleeding? Probably rather undershoot a little bit than overshoot, right? Especially if you're using this as prophylaxis. Now, if we're using it as treatment for a recent clot, it's a whole other ballgame, and let's talk about that. So, we know it's a slow-acting anticoagulant, so we know that the disappearance of the clotting factors is going to be over time. Now, what's really interesting to me anyway, I don't know if you'll find it interesting, is that the inhibition of the drug is inhibiting multiple factors. Now, the half-life of the factors is going to be different, right? So not every factor is going to be inhibited the same way by warfarin. So some factors are inhibited very quickly in the first few hours of the drug. So factor 7, that's one that is inhibited the quickest, okay? So factor 7 and protein C are both inhibited within 6 to 7 hours of the drug. Now prothrombin, factor 2, the inactive form of factor 2, which we know is one of the most active, right, in the formation of thrombin. We know thrombin is pivotal in the clotting cascade. It's really that brings everything together, super important for platelet aggregation in the clotting cascade. But this is not getting inhibited for 60 to 90 hours, 2 half-lives of the drug. So what do you think the problem is with this?
They're still clotting.
What? Yes,
You can still clot for a while.
Especially, you become hypercoagulable for the first few days after starting warfarin because you inhibit protein C, which is one of our antithrombotic mechanisms, right? That stops which factors?
2, 7, 9.
So that's warfarin. 5 and 8. So protein C/S, the protein CS system inhibits 5 and 7. I mean 8, I'm sorry. I always say that. Inhibits 5 and 8. So we're now inhibiting protein C, which is our antithrombotic control. And we're inhibiting factor 7 But we're letting prothrombin go wild and have a party, and thrombin is being produced and still being produced. In fact, because we've stopped protein C from acting, we now are actually not even inhibiting 5 and 8 anymore. And so now 5 and 8 are still not being inhibited, right? And in addition to that, prothrombin is still active. So for the first 2 to 3 days, we're actually hypercoagulable on warfarin. So what does that clinically tell you? So we need to protect the patient from forming a clot or from the clot that we're trying to treat getting worse.
Hi, sorry to interrupt again. Really quick, did anyone leave their car keys, Honda, Downtown Disney, keychain on it in the restroom? They were found. No? Okay, thank you. It'll be with Raquel if you know who's it.
Thanks, Chantal. Okay, so we need to protect the patient, right? So in a patient that has an acute clot or an acute stroke, is warfarin the best drug to start? No. And if you do have to start it, because you can't get another oral anticoagulant, remember, these patients are often in the hospital. We can put them on IV therapy or injection therapy, but when they leave the hospital, most patients definitely can't go home on an IV therapy infusion. Most patients don't really want to inject themselves. To us, it's like, oh, no big deal, we do that all the time. But for most patients, they prefer to not inject themselves. So they want to be on an oral therapy. So oftentimes, you know, while patients are in the hospital, we have them on an IV or injectable. We need to then transition them to an oral therapy for them to go home on. So if we are going to start them on warfarin, we need to bridge them. Bridging them means that we need to have them on another anticoagulant that's going to take care of this hypercoagulable period before their INR becomes therapeutic. Generally, it takes about 4 to 5 days to get to steady state to when our INR is 2 to 3. Now, what if in 2 days, Stan, my INR is 3 in this patient? Can I just say they're anticoagulated?
No.
No, that's right. Because I know that factor 7 is super important in the PT-INR level, right? I said that that's really measuring the extrinsic pathway. So I know that factor 7 is inhibited early, so of course my PT-INR is going to be affected by that. But it does not mean that the patient's not hypercoagulable for those first few days. We still have to treat that patient during those first few days as if they are not being anticoagulated until their INR is therapeutic. So in a patient that has an acute clot, acute stroke, whatever else, we need to do what's called bridge therapy. They need to be on another anticoagulant medication until their INR is therapeutic, and it has been 4 to 5 days. Both things. Okay, 4 to 5 days and their INR is therapeutic. At 5 days, if their INR is still 1 TIA, should you stop the other anticoagulant?
At how many days, sorry?
5 days. You're like, they're not hypercoagulable anymore. Fine. Why? What's up? Well, it's been 5 days though, right? So their INR is 1, it's been 5 days.
While they're taking
Yeah, so they're on both anticoagulants. They're on 2 anticoagulants, it's been 5 days. We said 5 days is the period, right? Yes.
Before you did the bridge, what was their INR?
So the INR was 0.5 before you started them on the medicine.
Okay, then it went
Now
up to
5 days in, their INR is 1, so we can say 5 days are over. So you want to take them off the bridge or no?
Can you wean them off the bridge?
They're not at therapeutic.
Yes, they're not. Their INR is not therapeutic.
That's what he said.
Right? Speak up. So their INR is only 1. Right? So yes, it's been 5 days. They're past the hypercoagulable window, but their INR is not therapeutic. Right? So they're not on enough of a dose to inhibit the factors enough to actually bring the INR to therapeutic level. Okay, so the patient not only does it have to be 4 to 5 days, but they also, it's an and the INR has to be therapeutic. If the INR becomes therapeutic at 2 days, we still can't take them off the bridge. We have to be at 5 days and a therapeutic INR. Is everyone clear on that? Yes.
Yeah. Isn't there a danger though that if they're on that like heparin and then they're already at their INR at 50 days that they can shoot too high up?
Well, does heparin affect the INR? Thank you.
So you have to take them off.
Well, you have to until they're up to therapeutic level in their INR, right? So you increase the Coumadin to get them to therapeutic level. Once they're at therapeutic level, 2 to 3 on their INR, you can stop the heparin. Okay? So it has to be 5 days and having a therapeutic INR 2 to 3. Okay, yes.
So earlier when you talked about how some doctors would say don't let
Doctors?
PAs would say don't let patients, tell patients not to eat green leafy vegetables because vitamin K, there's a lot of vitamin K dependent factors and that increases coagulation, right?
Let's back up. Okay, so say that again. So some clinicians, many clinicians, will tell patients to not eat green leafy vegetables because and then say the rest. Because they contain what?
It's vitamin K.
Okay, and then vitamin K does what?
Helps in the coagulation cascade.
Okay, and what does it do in the coagulation cascade?
It affects factors 2, 7, 9, and 10.
When it affects it, what does it do?
Stimulates.
Production
Production.
of those factors from the. Yes. Good. So let's just be really clear, right? So that we're understanding. So yes. Okay. So now what's the question?
So then so that's like pro cascade.
That's right. So that's going to increase the factors 2, 7, 9, and 10. Okay. Increase the ability of those factors to work when we're really trying to inhibit them. So we're kind of like acting against ourselves, so to speak.
So my question is, so say you have somebody, say you give somebody warfarin, okay. But they have like Crohn's disease or they have like celiac disease, and they have problems with gut flora, so they're not making vitamin K2, okay. And they're also not eating vitamin K1, so they're at more increased risk of bleeding then because
if they're making no vitamin K, which is like unheard of, right? At least you have like some bacteria in your gut to make vitamin K.
Yeah.
But that would be a patient that you would really need to consider, is that the best anticoagulant for that patient? Is inhibiting the vitamin K dependent factors in someone that we know probably isn't producing much vitamin K really going to be the best way to treat this patient, or is a different anticoagulant going to be better? And that's like a great point we have to treat every patient as an individual of what is the best therapy for that patient, right? So I probably would use an antithrombin therapy in that patient.
So an antibiotic always an indication, like you always gotta watch out whenever anybody's taking an antibiotic when you're
with warfarin?
Yeah.
Not any antibiotic, but a lot of antibiotic classes based off of that chart that I showed you, which is just even like a limited number, but a lot of antibiotics we use regularly, right? Cipro, Flagyl, clindamycin, tetracyclines, like those are all medications that change the CYP450. Either as an inducer or inhibitor. So any medicine that acts on those areas, we need to be mindful of. Yeah. And it doesn't mean doesn't require a panic attack, right? But it just requires us to say, okay, I'm doing this. Because I'm doing this, I'm going to make this adjustment, either up or down of the medication, and I'm not going to be negligent and not check an INR for a month. I'm going to check an INR in 3 to 5 days. Right? So it's requiring an increased level of, if you don't understand these things, then you don't know that you need to do this stuff, right? Then you're just like, oh yeah, I'll just check another INR in a month, that's what I'm supposed to do, right? But you're making clinical decisions that require you to then alter your normal path, right, of what you would do in a patient that's just chronically been on warfarin for years, okay? All right. So, bridge therapy can be done with a number of different anticoagulants that are either IV or injectable. Generally, we do use heparin, so either unfractionated heparin via an infusion if the patient's in the hospital, or low molecular weight heparin injections are great ways to bridge a patient for those first 5 days or until they're therapeutic on their warfarin. So initially, when you're first starting a patient, the INR needs to be checked more frequently, and then as you get stability in your patient's levels, you can check it less frequently. When you change or add a new drug, especially if you know it's inhibiting or inducing the CYP450, important to make sure you're checking the INR. And as you kind of get more comfortable with the patient's lifestyle and the stabilization of the anticoagulant, like I said, you can check less frequently. All right, so biggest adverse effects, bleeding, bleeding, bleeding. It's especially high risk for bleeding if you're using it in combination with another drug, like an antiplatelet, if the patient's older or has history of bleeding. And then warfarin skin necrosis. So warfarin skin necrosis is a complication of that hypercoagulable period for the first few days of patients being on warfarin and becoming hypercoagulable. So we can see skin necrosis where there's actually areas of the skin on the body, anywhere on the body, that can actually become necrotic. So you develop microvascular thromboses, which causes necrosis of the skin. I don't know if any of you guys have seen necrosis of the skin, or if I have a picture of it. I guess I don't. But it's basically where the skin dies and becomes black, like an Escher. And it starts off as being like almost like this purple color. It looks like almost like there's blood under the skin. And then the tissue just dies, and then needs to be debrided. So I've had a patient with breast warfarin necrosis. Actually, I had to have a mastectomy because of it. So it can be very serious.
Oh.
Right? So it's really an important thing to make sure that you watch for, warn your patients about if you're starting them on warfarin. Patients with protein and C deficiency that you don't know that goes undetected, then you're inhibiting the small amount of protein C that they already have, and they're at more risk for this as well. Contraindications, pregnancy, and if they already have a protein C and S deficiency, which we oftentimes, again, don't know about. All right, so we talked about why bridging. Does everyone understand why we need to bridge? Yes. Any questions about that?
I have a question that's not related to bridging.
Okay.
You said something about using the anticoagulant with the anticoagulant?
Yeah, anytime you're using dual anticoagulant or antiplatelet therapy together, your risk of bleeding.
Oh, it's just like, you just use them in conjunction just to decrease clot formation, right?
Exactly.
Okay,
So especially like in a patient that's had like multiple strokes or multiple MIs,
Okay.
you really want to make sure that the patient is well anticoagulated. Sometimes you'll see patients that will be on two, an antiplatelet and an anticoagulant,
Okay.
but it definitely increases the risk of bleeding significantly. Okay. Very good. So how high is too high? When do we need to worry for the INR? So there have been, people get scared about having an elevated INR. I've had patients with INRs of 14 that don't bleed. So in those patients, it's a really big debate about what do we do, right? So now if a patient comes in with an INR of 5 and they're bleeding, what would you do, Chrissy?
Stop the warfarin.
Okay, so we'll stop the warfarin, and when is the warfarin going to get out of their system?
5 to 7 days.
You're bleeding, sir. I'm going to stop this drug. Not to worry. It'll be out of your system in 5 to 7 days. So in the meantime, I'll just give you a lot of blood. What else would vitamin K? Okay, so we could give vitamin K, right? Which is, now we need to give vitamin K that is basically vitamin KH2, right? So we want to overcome, right? But we either need to give vitamin KH2 or some other vitamin K, right? Now we have that drug Coumadin in the system, right? So if we give vitamin KH2, until the levels of the Coumadin come down, that KH2 is going to be inhibited, right? So we have to give a large amount of vitamin KH1, right? That's going to be active and bypass that reductase enzyme, right? And make those factors 2, 7, 9, and 10. Good. So in the meantime, so that's probably going to cause, does the factors get produced like immediately? No. So that's going to help us. So good, I like that idea. Let's give some vitamin K. What else should we do? What's that? Fresh frozen plasma. Okay, so we can give fresh frozen plasma. Fresh frozen plasma has all of the factors in it, right? But it's not concentrated. So in order to get a large amount of factors, you have to give a lot of fresh frozen plasma, which is a lot of volume. So we can also give cryoprecipitate, which is where we actually spin down and remove the plasma and actually just get the precipitated factors. More bang for the buck. You get more of the factor in a smaller volume, so less likely to volume overload the patient. And there's actually a drug that was created, or a medication that was created called K-Centra, which is factors 2, 7, 9, 10, protein C, and protein S. And actually is used specifically to reverse the effects of warfarin. So in patients that are bleeding, we're actually replacing the factors directly that we know are inhibited by warfarin immediately. Okay, so those are all good strategies to stop the drug, give vitamin K, and then if they're actively bleeding, we need to reverse the warfarin. Now, if they're not, the question is what do we do? Because when we give things like vitamin K, it causes that INR to come down eventually after several days, but then it's very hard to get the INR back up when you need to restart the warfarin. Okay, so it takes, because the half-life of this drug is so long, it takes a long time, right? So the process of reversing an INR and then getting it back to therapeutic could be weeks. Okay, and so if a patient's not bleeding and their INR is between 4 and 10, there is some debate about whether or not to give vitamin K, and if we do give it, how much do we give, right? But if the patient's not bleeding, we generally don't replace factors. Okay, we only replace factors if the patient is actually bleeding.
So if they're at 5 or greater and they're not bleeding, you just taper down the warfarin?
So you can decrease the dose, maybe you hold the dose for a day or two, decrease the dose by 50%. And it's really debatable. If for a patient with 5 that's not bleeding, I would not give vitamin K. Yes?
Wouldn't you have to figure out what caused the increase in the INR? Like,
Absolutely, absolutely,
like, okay.
yes. I mean, you at least need to try.
Yeah.
Right, but sometimes, patient will just say like, I wasn't feeling good, and then I haven't really been eating for the last few days, and their INR shoot up, or they started taking an antibiotic that you don't know about, or something unusual will happen. Okay. So this is not the Bible with this, just so you know. This is just kind of giving you an idea of like, okay, what are some things that I should be doing? There is no exact, I might tell you, okay, for INR 5, I'm not gonna give vitamin K because it's gonna take me forever to then get the INR back up. Someone else that's a little conservative might tell you they are. Like this algorithm for 4.5 to 10 tells you to give a little bit of vitamin K. But you're gonna have a really hard time if you start giving vitamin K trying to get the INR back up. So you want to just be judicious with that. Now, if they're bleeding, all bets are off. You give them everything, right? Because we're trying to save their life. Give them vitamin K, give them FFP, give them fresh frozen plasma, cryoprecipitate, K-Centro, whatever you can. Okay. All right, so reversing warfarin. So we give vitamin K1. We can give it IV, oral, or subcutaneously. Subcutaneously is a little bit less desirable because the absorption is not really well known. IV works really fast, or faster than oral, but there is a small risk, less than 1% risk of anaphylaxis. I've given a lot of vitamin K. I've never seen a patient have anaphylaxis, but I imagine if I did, it would change my opinion about vitamin K being an IV. And as I mentioned, you can also give FFP or prothrombin concentrate, complex concentrate, or K-Centra. Yes, Tia?
Oh, sorry.
Just stretching? Okay. All right. Let's take a break, because I feel like my voice is like, people are falling asleep, some of the stuff, and when you actually understand it, it makes sense, right? And I can see like the ahas happening, that's really important. If you don't understand it, it just becomes this like memorization of like, wait a second, she said this one thing, and like I don't get it, right? But it actually, the stuff is really important to understand. All right. Oh, you have the sugar high from your candy corn yet? So the last part of this lecture, so we've gone through 53 of like 90 slides. And really the majority of what I talked about, we've already covered. So now we just have to review the drugs and then do our post-test, right? So warfarin, in my opinion, is like the most complicated of these drugs because the mechanism of action and the things that we have to think about are pretty complicated. But now we're going to talk about the indirect thrombin inhibitors. So when I talk about an indirect versus a direct, so is vitamin K dependent anticoagulant warfarin? Does it have a direct or indirect effect?
Direct.
Explain that to me, Emmy.
Because you're being hit by vitamin K, not directly.
Very good. So you're not directly inhibiting the factor. You're doing something to then affect the factor. So you're not inhibiting the factor directly. So if David is 10A, I'm not binding to him and making him ineffective, right? I'm just saying, like if she is dependent, if Stephanie, right, then needs Emmy to become David, I'm inhibiting Emmy so that David's not able to be formed, right? That's inactive. I mean, not inactive, indirect, okay? So that's the difference, okay? So right now we're talking about indirect thrombin inhibitors, and pretty soon we're gonna talk about direct thrombin inhibitors. So inhibiting thrombin directly, right, versus indirectly. So we talked a little bit about how does heparin inhibit thrombin indirectly. How? Yes. What did you say? Say it louder, Bill. Antithrombin, which used to be called antithrombin 3, right? So we're having the effect on antithrombin, which is then having the effect on thrombin and 10. Okay? So that's why it's called indirect. All right. So what happens here are that these two factors are inhibited. So that's part of the common pathway here. Right? 10A is really part of everything, but mostly common. So just so that you guys know, heparin, both products are made from either cow or pig, which is also insulin is also porcine or bovine derivatives. So if a patient has an allergy to either of those things, be mindful of that. Additionally, so the mechanism of action. So what happens is antithrombin is a molecule, and its name says what it does, antithrombin. So it is but the body's natural mechanism of stopping the coagulation cascade from continuing on when its job has been done. So what does heparin do? So heparin actually binds to antithrombin, which is also called heparin cofactor 1. And what happens is that by binding to that site, it causes the antithrombin to make that conformational change, kind of like which receptor and the platelet receptor when fibrinogen or von Willebrand factor binds to it. Okay. What was your question? Okay, so we said a conformational change happens, right? A conformational change is when it goes from looking one way to another way. Right? And generally it's when it becomes activated. So in platelet activation, good. So when the G2A, B3B gets bound by von Willebrand factor and fibrinogen, it changes its conformational shape and activates the platelet. It's okay. It changes the conformational shape, right? And allows that to activate. So same thing is happening here. When heparin binds to antithrombin, it does this magical thing where this conformational change happens. And after that happens, what happens? Now remember, heparin is something that naturally occurs in the body, right? So there's small amounts of heparin in the body all the time, right? Basophils have some heparin in them. There's small amounts of circulating heparin. So this is happening all the time in the body. Now I'm talking about giving exogenous heparin and causing this to happen, kind of like in a way that is much more powerful than what's naturally happening in the body. So I give heparin exogenously from the outside in, causes this conformational change, and then it makes antithrombin go from just kind of la 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 to doing its job really fast and really hard. And it's about 1,000 times more potent after it undergoes this change to actually cause those anticoagulant properties. All right, so very, very important to know this is an indirect thrombin inhibition by antithrombin. Right, by the way of antithrombin. So then what happens is it inactivates all of these factors, mostly in the intrinsic pathway, but it's really inactivating thrombin and 10A. Okay? So by inactivating thrombin and 10A, we're then going back to here. We inactivate these, we're inactivating these two. Okay, so we're inactivating all of this stuff, including this over here. So all of the stuff from above becomes inactive. Okay, so it kind of stops that clotting cascade kind of in its tracks, right? So it's unable, though, to bind fibrin-bound thrombin. Remember that in that platelet clump that starts to form, that gets those red cells in there when those platelets have their pseudopause, and the thrombin actually binds to the PAR1 receptors and activates, right? So when all that is happening, there's thrombin inside the clot. If this is unable to bind to thrombin-bound fibrin, what does that tell you clinically? What is it not going to do? Is it not? It's not going to get rid of the clot. Everybody thinks I'm going to put your patient on heparin, it's going to just dissolve the clot, right? Your patients are going to ask you this. Is that what happens? No, it is not. So what is the point of it? To stop the propagation of the clot and avoid new clots from forming. It is not going to dissolve the clot. If it's not going to dissolve the clot, then what do you do about the clot? So you can either give a fibrinolytic, but we are usually not going to do that in combination with an anticoagulant because patients are at high risk of bleeding with fibrinolytics, right? But in a patient that has a clot in a really high risk area, fibrinolytics are a great choice if you don't have other options to open the vessel. What was my question? What did I ask you? Oh, so what if your patient asks you, well, what about the clot? What are we going to do about the clot? So if the clot's not in a vital area, then we can let the clot resolve on its own. The body will break the clot down over time, generally 7 to 10 days, the clot will start breaking down on its own because we know the body has these mechanisms to do that. So if it's in a place that is blocking blood flow to a vital organ, then yeah, we need to probably do something else other than this, right? But if we're just trying to stop the propagation of the clot, then we can do this. And as long as it's not in a life-threatening area, they're still getting blood flow to that area, like somebody has a, let's say a DVT, right? And they're like, and it's not in their arteries, in their vein, right? Arterial thromboses, totally different story, okay? We're talking more about venous thromboses now, remember? Because we talked about clots in the venous system being more with the coagulation factors and red blood cells, clots in the arterial system being more platelet rich, right? So are you guys making those links now? Okay. All right, so heparin prevents thrombosis from spreading, but does not lyse the clot. Really important to understand. All right, so this is a nice little picture for those of you that are visual learners showing you that unfractionated heparin here. It's this longer molecule. It's going to bind to antithrombin, make this nice little picture here, and then it's going to inhibit factor 10 and inhibit thrombin. Now, low molecular weight heparin is a shorter saccharide here, and it is going to not inhibit thrombin so much, but mostly inhibit factor 10A. It's not going to entirely inhibit factor 10A only, but mostly. So we're not getting as much thrombin inhibition with the low molecular weight heparins, okay? And that's just based off of the size of the molecule. So unfractionated heparin is the first heparin that was produced. It has to be given in 3 different ways, either intravenously for treatment. So it has to be given in a continuous infusion. It can be used subcutaneously in injections for prevention of a DVT. And a long time ago, we actually used to use it for treatment of DVT, but it is generally not used for treatment of deep vein thrombosis at this point. So unfractionated heparin uses antithrombin to inhibit both 10A and thrombin. Notice the red circles here, they're both the same brightness, okay? All right, so it's really mostly used in the hospital setting. It is given, again, by an infusion most of the time. It can also be used to given for prophylaxis, meaning like somebody's hospital bound and we're trying to prevent DVT in that patient. We can also give subcutaneous injections, but those have to be given 2 to 3 times a day. Most patients, as you will find out, do not want to be injected with something 2 to 3 times a day. If they have to be, they really don't want to get it more than once a day. So it becomes a little bit of an issue that patients are not really super happy about. So how do we monitor heparin? TTT. Remember the TT like the H. Do not forget that. Now, anti-10A levels, because it inhibits both thrombin and 10A, can also be used to measure it, but generally APTT, PTT, is the standard for monitoring heparin. It's pregnancy C. So pregnancy C, and actually I should change this because they've changed the grades from A to D and X to actually numerical grades. But pregnancy C basically means we don't really know the effects in humans. What we have seen is that it doesn't cause any problems and that it's safe. We know that low molecular weight heparin is definitely safe in pregnancy. Unfractionated heparin, we're not 100% sure of the risks of, but it certainly has not been shown to be teratogenic, like warfarin. Adverse effects, of course, bleeding, heparin-induced thrombocytopenia, which we will learn about in hematology next semester. I'll talk a little bit about that. It's pretty complicated though. And then it is highly protein bound. So states of acute inflammation can decrease efficacy, which oftentimes people will say, oh, that's heparin, the patient's heparin resistant. Do you have a question, Toby? Yes. What's up?
So you said to prevent stromal bones in surgery in medical patients. So in a patient, let's say like an orthopedic patient, would this be okay?
Yeah, so it depends, right? So this would not be my first choice for prophylaxis in a patient that's in the hospital ever, because it has to be given 3 times a day. The peak and trough of the drug, so the drug, its half-life is very short. So what happens is you get a peak, a trough, a peak, a trough, a peak, a trough, right? So in this times when the patient is at the trough, right, they're not very well anticoagulated, right? So I would prefer a drug that's more like this, right? So if we're giving it once a day, we're getting more of this effect rather than up and down where the patients are at levels of throughout the course of the day where they're at risk of having a clot, right? I much would rather a drug where I'm really staying mostly here, right? I'm never dropping down. All right, so this would not be my choice for giving patients that have had orthopedic surgery prophylaxis. Now, with that being said, there's a big controversy about what to do in those patients, right? Some people will actually give therapeutic anticoagulation to patients for 3 months after surgery. So patients will actually be on warfarin or low molecular weight heparin injections for 3 months after surgery. There's a big controversy about what we should really be doing in patients that after post-orthopedic surgery. It's kind of like a whole other discussion. But basically, in the hospital is definitely different than when they go home, right? Because in the hospital, we have much more control. Now, when they go home, if you still want to continue them on anticoagulation therapy, then that's a whole other conversation. In the hospital, generally we give low molecular weight heparin. It's 1 injection a day, 40 milligrams of low molecular weight heparin a day, and it has a superior efficacy to unfractionated heparin. And that's really because of the pharmacokinetics of the drug, right? You're having much shorter periods where the patient is under anticoagulated, whereas with that drug, you're having peaks and troughs because of the half-life of the drug. So the half-life of heparin is 4 to 6 hours. So we shut that drip off, right? If you're on a heparin drip and you need to go to surgery, I can shut the drip off and 4 hours later the drug is gone, which is great, right? Or if I want to anticoagulate Christian because he has a pulmonary embolus and I'm worried about him bleeding because I know that he has an AV malformation in his stomach that has been documented. If I put him on heparin and monitor him and he starts bleeding, I can shut that drug off and 4 hours later it's gone. Versus if I give him warfarin or some other long-acting anticoagulant, I'm a little bit screwed for a little while until I can reverse that drug, right? Does that make sense? Okay. So here it says heparin is highly protein bound. States of acute inflammation can decrease its efficacy. Can someone please explain that to me?
Isn't it when you're highly bound to proteins, you have like a lower volume of distribution?
Yes. Okay. So if you're protein bound, what protein is that generally to?
Albumin.
Good. So if I have a steady amount of protein binding, right, and free drug, and that's consistent, then my volume of distribution of the drug is going to be same over time, and my anticoagulation is going to be consistent. Now, if I have something happen, like I become septic because I have an infection, I become acutely inflamed, what happens to my protein? Albumin. It's a negative acute phase reactant. What goes up? What goes up? Okay, so cytokines go up. Okay, leukotriene might go up, prostaglandin, the whole prostaglandin cascade goes. What else goes up in the blood that's measurable during inflammation? That's a positive acute phase reactant. You guys learned about this in lab when we did the ESR test, right? So the ESR test in acute phase reactants, right? You're acutely inflamed. There's something that goes up in the bloodstream that causes more inflammation that increases our ESR. It makes those cells drop. What is it? Yes! Fibrinogen. Fibrinogen is an acute phase reactant that is positive. It goes up in inflammation, just like ferritin, transferrin, other proteins. However, albumin is a negative acute phase reactant. When you have state of inflammation, albumin goes down, which is why we do not use it to measure nutrition in a patient. Because if I measure your albumin and you're acutely infected, it's going to be low. And that is not going to tell me about your nutritional status. It is only going to tell me how much circulating albumin you have at this very short period of time, right? So if that's going down, right, the volume of distribution of the drug is going to be changed. So that bound drug, which in this case is actually the active form of the drug, is when it's bound to protein. So if now I have less protein and I have more free drug that's inactive because it's not bound, it's going to be less effective, right? So things that change our protein levels in the blood and make them lower are going to change our ability to have a therapeutic level of the drug in circulation. And some drugs it's the free part of the drug that's active, and some it's the bound. So you have to understand that. But in this case, if a patient's albumin levels drop, they may be seen as being heparin resistant, even though they're not heparin resistant. They just don't have enough albumin around to actually make the drug efficacious.
So how heparin is not a
If a patient is like, so if the patient, well, it's because it's protein bound. Yes. So if there's a significant decline in the albumin, right, that's going to affect the volume of distribution of the drug and the activity of the drug. Yeah. Okay. Yeah.
Did you say that the heparin was active when it was bound?
Yes. Okay. So, how do you dose it? So if you're giving prophylactic doses, which probably by the time you guys start practicing, I don't even know if we're going to be really using this much anymore. You're giving 5,000 units twice or 3 times a day. The half-life is 30 to 90 minutes of the subcutaneous heparin. In the IV drip, the half-life is 1 to 2 hours. I think I told you 4 to 6 hours, but really what I should have said is it's totally out of the system in 46 hours. The half-life is 1 to 2 hours. So for the drip, it's continuous. So the patient has to be hooked up to the IV all the time. GTT means drip, for those of you that don't know. And that is actually, guttate is the Latin word for drip, G-U-T-T-A-T-E, and so that's where that comes from. Dosing is done using boluses. So what happens is I want to put David on a heparin drip. I want him to be anticoagulated immediately. So I'm going to give him a bolus, meaning a big dose. I'm going to take this water bottle and dump it into his bloodstream to try to get his PTT at therapeutic range quickly, within like minutes to hours. Then I'm going to put him on a sustained dose of the drug that's going to trickle in to keep that steady state, right? Just like our antiplatelet drugs. We give a big dose, then we give a littler dose every day. But with the drip, we're going to bolus, and then we're going to try to keep it at a therapeutic level. 60 to 80 seconds is a therapeutic level for heparin. Now, if I want to keep checking his PTT every few hours to see where I'm at, right? So every 4 hours or so, generally you check a PTT level because the half-life is 1 to 2 hours. So I'm going to bolus him. I'm going to start him on a drip rate that's weight-based. I'm going to check a PTT in 4 hours. If it's 40, what should I do?
Keep going.
Keep going. So should I just keep going at the same drip rate?
Yeah,
So I need to probably bolus him again and then increase the drip rate. Check a PTT again. Now it's 100. Now I got to decrease it, right? So I got to decrease the drip rate, right? So you can't take away a bolus, obviously. It's not like you can suck it back out, right? So if I overshoot and I'm too high, the only thing I can do is decrease the drip rate or hold the drip. So there's all these protocols that are written by pharmacologists based off of the pharmacokinetics of the drug that tell you exactly what to do, and every hospital has their own protocol. So usually it's nurse-driven. The nurse has a protocol, draw PTT every 4 hours, adjust accordingly. Now that's fine as long as you have a run-of-the-mill patient. But let's say you have a patient that is not run-of-the-mill, there's other things that you need to factor in. You might want to drive that. And so it's important for you to know, as a provider, how do I adjust the drip? So you look at that protocol and look at your specific patient, and then you can make adjustments based off of that recommendation. Maybe you're really worried about bleeding in David, and so you don't want to bolus him, right? So even if he's 40, you're going to err on the side of caution and just increase the drip rate, right? So it also depends on the patient. But generally, the protocol is written by pharmacology based off of the pharmacokinetics of the drug, and the nurses can drive the protocol. They don't have to call you every time they adjust the drip. Heparin is eliminated by the liver, so make sure that obviously the patient's liver function is appropriate, and you want to monitor with the APTT, PCT. Do not forget that, because that will definitely be asked on your test. So any questions about heparin, unfractionated heparin? So we're only right now talking about unfractionated heparin. So it's either given IV continuously or subcutaneously for prophylaxis of DVT. It is not used subcutaneously generally to treat DVT that's active, okay? But the drip is. We use the drip all the time. The drip is great for patients that we need to do procedures on. We can stop it quickly, right? It's very short acting. We can also use it to bridge with warfarin. Let's say Christian comes into my office, he has a big pulmonary embolus, I send him to the ER. We start him on a heparin drip right away. We know he's not gonna be on a heparin drip when he goes home, but all his insurance will cover is warfarin. So we put him on the heparin drip and the warfarin to keep him anticoagulated for 5 days or until
therapeutic
and until his INR is therapeutic, which is 2 to 3, and then we can stop the heparin drip and send him home on the warfarin. Okay? All right. So adverse effects include bleeding, of course, heparin-induced thrombocytopenia, hyperkalemia. So interestingly, heparin inhibits aldosterone production. So that is because it actually decreases the affinity of angiotensin II receptors in the zona glomerulosa. So over time, prolonged heparin use can cause reduction of the size of the zona glomerulosa and reduction of aldosterone production. Generally, we monitor, make sure that their potassium levels are stable. It's pretty rare that this actually becomes like a major issue. Osteoporosis is a side effect of long-term use and elevated liver enzymes. So one good thing, well, an additional good thing about heparin is that there is a reversal agent. So protamine is an antidote to heparin. Definitely know this. It binds to heparin and inactivates it. It must be administered slowly because rapid administration can be associated with hypotension, cardiovascular collapse, pulmonary edema, pulmonary hypertension. It only reverses about 60% of the drug, so it's not going to fully reverse heparin. But it works pretty well and is great if a patient is bleeding. Again, heparin is a fairly short-acting drug anyway, so it's going to be out of the system in just 4 to 6 hours completely. But protamine sulfate can be used to reverse it as well. All right, so just a quick word on HIT. So HIT is an acquired disorder. There's 2 types. Any patient that has been exposed to heparin can be at risk for HIT, especially if it's a second exposure. Incidence is pretty low, 3 to 5% of patients in unfractionated heparin. Much, much, much lower in low molecular weight heparin, right? It's like 0.6% in low molecular weight heparin. But in patients on unfractionated heparin, 3 to 5% is a good number. It can be life-threatening. So what happens is antibodies form to heparin platelet 4 and complex together. And these antibodies bind to the platelets and activate them, which leads to thrombocytopenia and a prothrombotic state. Thrombocytopenia and a prothrombotic state. What? Tell me about that. So what happens is the drug, you give the drug, it causes an autoimmune reaction, basically, where IgG forms. IgG, right, immunoglobulin, forms, binds with platelet factor 4, which is a normal heparin platelet factor 4 that is released by our platelet granules. Once that happens, now like the drug, right, is really like neither here or there at this point, because whether the drug is still present in the system or not, the immune system is now active in making these complexes. So even if you take the drug away, once this starts happening, this happens until the IgG is no longer around, which is months, right? So what happens is these IgG and heparin platelet factor 4 complexes are binding to the platelets and then causing thrombocytopenia and clots. So how can we make sense of thrombocytopenia and clots?
So
So the cells are clumping together, decreasing the count.
Yes! Very good! So the cells, right, those platelets, remember when we saw in that video how the platelets come and come and come and come, and when they do that in circulation, they're decreasing, right? So that's causing thrombocytopenia in circulation in the serum, right, when we're checking. But they're clotting, right? And it's basically called a consumptive coagulopathy. So these guys are coagulopathic, they're forming clots, but the platelets are being consumed in the clots. So in circulation, the platelets look low. They're actually clotting, and they're low because they're clotting. That's a really dangerous thing, right? So these people have low platelets, but they're clotting, and then we're like, oh, crap, what do we do, right? They're clotting, but their platelets are low, right? It's a major problem. So the risk of bleeding and clotting, but more commonly, the clotting becomes the problem, okay? So there's two types of hit. One that is not really immune, it's very transient, bless you. It happens to patients within the first couple of days of heparin exposure, and it goes away on its own, right? So we see it, and it goes away. Hit type 2 is immune-mediated and is dangerous. It's life-threatening, usually happens about a week after we give the heparin, and generally we see that the platelets decline by at least 50% from prior to the heparin exposure. Make sure you always get a CBC prior to starting heparin, okay? And you need to monitor that CBC in a patient in the hospital that is on heparin, okay? Now, a patient could have been exposed to heparin therapy while in the hospital, go home, right, and still develop HIT, right? So they might come into your office a week after hospitalization with platelets that are 50,000, and you're wondering what the heck happened. Better find out if they got heparin when they were in the hospital. Because if they have HIT, those antibody complexes are gonna hang around for like 3 to 6 months. Right, IgG lives for a long time in the body. So these complexes, now the patient gets administered heparin again. What do you think happens? Right, so now the antibody complexes are already there circulating. That's 7 days, no longer. That's gonna happen immediately. You give that patient heparin, those antibody complexes are circulating, you just activated it, and those platelets are gonna be gone in a second, and HIT is going to take over, right? These patients are going to clot. So in patients that have HIT, they need to be on anticoagulation. So they actually need to be on therapy to prevent these clots from forming until this IgG response has gone away. And then what do you think that we need to be really, really, really careful of? Is that? Sure, always with anticoagulation. But what about specific to this patient? Like Emmy, she's my patient, she's a little old lady, she went to the hospital last week, she comes into my office, her platelets are 50, I asked her if she got heparin, she says, oh yeah, I did, they were giving me the shots in the belly, so I put her on anticoagulation, and then what do I want to make sure is documented? What's that? Definitely a CBC, right, because I want to monitor.
Patient teaching?
What's that?
Patient teaching?
Patient education.
Patient education.
Okay, so patient education,
Yeah.
about what?
About like, the medications that they're taking, drug interactions,
Okay, good.
and like they're saying,
Patient to fall,
yeah.
right? Okay, what else? You don't want to kill the patient. Okay, so what could kill the patient? Yes, heparin. Ever giving that patient heparin again? So it should be listed as a allergy, right? Do not ever give life-threatening allergy. Okay. Heparin allergy, okay? This patient should never, ever, ever get heparin again. Everybody clear on that?
Ever.
Okay. Ever, 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 ever again. Okay? Because this will happen, and it will happen faster the next time around. Okay? So this is just a little picture to show you guys what happens. You can look over that on your own, but basically, exactly what I explained. So IgG is going to bind, it's going to form this immune complex, it's going to bind to the platelet, make the platelet really sticky. Platelets are going to clump together, platelet activation is going to happen, and the patient is going to have clotting and thrombocytopenia. So does the amount of heparin exposure matter? No. So we use heparin for flushes, IV flushes, line flushes, dialysis, right? So even just a small exposure to heparin, a small amount, does not have to be therapeutic dose heparin or heparin drip. Yes.
Is it just unfractionated heparin, or is it the low molecular weight?
You tell me.
I'm asking you.
I already told you the answer to that.
Did you?
Yep.
So
Who can tell us?
wait, what was the question?
Is it just unfractionated heparin, or is it low molecular weight heparin too?
Oh, just a really small,
Yeah.
6% or less than 6.
Okay, so 3 to 5% risk of hit in unfractionated heparin. Low molecular weight heparin, much lower risk, 0.6%, but still at risk. Still at risk, but much less. Okay, by like tenfold. Okay, so I told you guys what we see, decrease in platelets by 50% in about a week. Bleeding is rare, but thrombosis is really, really common. So about 50% more commonly in venous than arterial. Obviously, arterial thrombosis is much more risky than venous thrombosis, but still both can lead to life-threatening events. So what do? Stop the heparin immediately if they're still on it. And we need to put them on a non-heparin anticoagulant until the diagnosis can be made. You can use either a direct thrombin inhibitor, argatroban, or bivalirudin, or fondaparinux, which we haven't talked about yet, so keep that in mind. Fondaparinux, if we go back to the slide that has our drug names, fondaparinux is in the heparin family. So, all right, let's think about that. How could we use a drug that's in the heparin family to treat HIT? But, all right, we'll come back to that. So what we should expect is if we treat the patient, right, that the resolution of the thrombocytopenia, that the count should return to normal. But remember, those antibodies will persist in the body for 3 to 6 months. This says 2 to 4, but 3 to 6, whatever, it's what we're saying. So that patient needs to be anticoagulated during that time. And you need to make sure that that patient is not exposed to heparin ever, but especially during that time. Okay. So heparin needs to be listed as an allergy. This patient should never, ever, ever get heparin again. Low molecular weight heparin, similar. Still binding to antithrombin 3, which converts that antithrombin from slow to rapid acting. But it's going to, because of the size of the molecule, it's going to inhibit more factor 10A than thrombin. Just because of the size of the molecule. So this is very safe in pregnancy. We use it to treat patients with ST elevation MIs, or use it for prophylaxis in patients that are at risk for embolisms while they're in the hospital, right? They're bedbound, post-orthopedic surgery. We can also use it for treatment of DVTs and PEs. And it has gotten a lot of clout in using as an anticoagulant for treatment of patients with DVT or PE that have a oncologic diagnosis. So warfarin has been shown to be dangerous and not have as good of efficacy in oncology patients as low molecular weight heparin. Can anybody think of a reason why that might be? So cancer drugs can affect the CYP450 system. Good. What else? Think about a patient that you know that's gone through cancer treatment.
People that hurt themselves, like their platelets.
Okay, so yes, so chemo can affect your platelets and your bone marrow function. So now I have this patient that's platelets are, I know that they're every month when I give the chemo, their platelets are gonna drop. Is warfarin an easy drug to stop and start? And no, the half-life is long, good. So patients that have thrombocytopenia, it would be a nightmare trying to start and stop the drug, right? Just try to get them up to the right level, then just in time we get them up to the right level, now I have to stop it. So it has that up and down, up and down. What else? Is chemo and radiation easy? What are some major side effects of nausea? Nausea. Nausea comes with vomiting and poor appetite. I don't want to eat. Dietary intake's inconsistent. You know, while I'm at the end of my cycle, I'm feeling good, I'm eating a lot, but while I'm in my cycle, I'm not eating anything. Variable vitamin K absorption, right? So I'm on antibiotics prophylactically because I'm neutropenic, so my vitamin K, H2 levels in my gut are all over the place. Not a great drug. So low molecular weight heparin is a great drug for cancer patients in treatment of DVT and PE. It is eliminated renally, so it needs to be dose adjusted for renal function. So, and we monitor it by checking 10A levels, right? So think about, when I ask you these questions on a test, think about, what is the drug doing? Oh, it's inhibiting factor 10A. So how do you check it? Check 10A levels, right? So, you know, it kind of makes logical sense for the most part. So when compared to unfractionated heparin, the bioavailability is better. There's a longer half-life. It's 4 0.5 to 7 hours versus 1 to 2 hours. And it just has that more predictable response where they're getting a plateau rather than the shorter acting drugs where we're kind of up and down and all over the place. Remember, low molecular weight heparin is a smaller molecule than unfractionated heparin, predominantly inhibiting factor 10A, not so much thrombin. So because it's inhibiting factor 10A more than thrombin, we have a very red circle here and a light pink circle here, indicating that we're mostly inhibiting 10A, not so much the thrombin. All right, so this is weight-based. It's given subcutaneously. Depending on the weight of the patient, you can give it twice a day or once a day. It's great for outpatient management. Insurance companies don't like to pay for it, so it's a little bit more expensive. But especially in an oncology patient, that's an indication for sure. Check 10A levels for monitoring. It doesn't really require monitoring, but in patients that's renal function are abnormal or is under or overweight, checking levels is a good idea. So we should check a level that is drawn 4 hours following a dose after at least 3 doses have been given. Why?
Because of the half-life.
So the half-life is 4.5 to 7 hours. So why does the half-life have anything to do with it?
Because it takes a certain period of time before you get to your steady state.
So, and that's not specific to the half-life, right? So what this says is a factor level should be drawn 4 hours following a dose after at least 3 doses have been given.
So this is more of a steady state.
Right, so it has nothing to do with the time, right? If I told you like it should be drawn at 86 hours, well then yes, you're right, it has to do with the half-life, right? But really, for any drug, if you want to check a level, you need to wait till it's at steady state. 3 to 5 doses. So if the dosing interval is Q12, then you wait 48 hours. If the dosing interval is Q24, then you wait 3 days, right? Or at 4 days, really, comes after the 4th dose, right? So does that make sense to everybody logically? That you want, anytime you're drawing a drug level, don't draw a drug level after the 1st dose. You have to wait till it's at steady state, right? And for every drug, depending on the half-life, that's going to be a different time, right? A different amount of hours. Clear? Questions? Okay. So protidine can be used as reversal. Adverse effects are the same, much less likely for low molecular weight heparin than unfractionated heparin for HIT. Otherwise, the reactions are really the same. Everybody's clear on HIT. So it's more common, Kiara, in what?
In the unfractionated.
Good. So unfractionated heparin, much more common. Low molecular weight heparin still happens, but much less common. Got it? Everybody's clear on that. No one's going to get that wrong on my test. Perfect. I see everybody like perks up.
The protein reverses it at 60%.
About approximately 60% of the drugs. So
what about the unfractionated?
Both.
Okay.
Yeah.
But since you can use heparin to reverse it, right? You said that heparin.
Protamine sulfate.
Yeah. No, you said there was like a drug that was in the heparin family that you can use to treat HIT.
Well, we're going to talk about whether or not should we really be using
Oh, okay.
it.
I was going to say, so you don't get an allergy to all heparins since you can use it as.
Well, that's so really like we should list heparin family drugs as an allergy.
Okay.
And we should treat with a non-heparin anticoagulant, right? Like the Valerudin family or Argatroban. There are some studies that have shown fondaparinux, which is in the heparin family, but it's not the same as the heparin, can be used to treat HIT. However, I'm extremely uncomfortable with that prospect. And there was one patient in a case report that actually there was a question of whether or not there was a HIT reaction in a patient on fondaparinux. Although it is widely accepted that fondaparinux, although it's from the heparin family, does not cause HIT and can actually be used to treat patients that have HIT with unfractionated or low molecular weight heparin. However, it makes me a little uncomfortable because it's still a heparin family drug. So let's talk about it. So fondaparinux was recently approved in 2001. That seems recent for me, but probably not so recent for you guys. This drug is part of the heparin family, but it's an indirect factor 10A inhibitor. And so it selectively inhibits factor 10A via antithrombin, but has no inhibition on thrombin at all, just 10A. So there's a question about whether or not we can use it in patients with HIT, but I think that it's because, and the reason for that is that it doesn't really have blessing platelet factor 4 binding, which heparin does, but I still think that it's a little bit risky. It can be given subcutaneously daily. Its half-life is longer. It's about 18 hours. It's given again as an injection. It's renally eliminated, so it does require dose adjustments and factor 10A levels because that's what it inhibits, is how you monitor it. Adverse effects are here. HIT, questionable. Like I said, there's a case report. It's not really clear. Some studies will actually tell you you can give it to treat HIT, although I am skeptical. There is no reversal agent available. So if there's no reversal agent available and it's under investigation, what can you give? What's that? What could you give to reverse this? Specifically, so plasma would be giving all the factors, right? Factor 10. Factor 10, right? You can give factor 10. So actually, and I probably should update this slide because the direct 10A inhibitors, they recently came up in May of 2018 with an antagonist. That antagonist can also be used here. So really, this should not say not currently available. I forgot to update this slide. Sorry. So contraindications. Endocarditis, patients that are less than 50 kilograms, bleeding, or creatinine clearance less than 30 mils per hour, this drug cannot be used. All right, so remember, it's only inhibiting 10A, and it's an indirect 10A inhibitor. So why is it an indirect 10A inhibitor? Because it's inhibiting antithrombin. I mean, it's activating antithrombin, not inhibiting it. So it's not directly inhibiting the factor, but it's actually still antithrombin initiating, which is why it's part of the heparin family, right? Because really only the heparin families are working on antithrombin 3. Everyone clear on that? Okay. All right, so all levels are not created equal. So what I mean by that is, depending on the drug, the 10A level that is going to be considered to be therapeutic is going to be different. So it's important to make sure that you know what is considered therapeutic for which drug. So for unfractionated heparin, a 10A level of 0.3 to 0.7 is okay, 0.6 to 1 for low molecular weight heparin. So low molecular weight heparin, there's 2 drugs that are low molecular weight heparin. So enoxaparin is one. What's the other one? So there's 2. What's that? Yes, dalteparin, which is also called fragment. So dalteparin fragment or enoxaparin low enox. Okay, those are the 2 low molecular weight heparins available on the market right now. All right, so direct thrombin inhibitors. Those are our hirudin family, ribavirin, argatroban, and dabigatran. So dabigatran, we said, was our first NOAC agent. Okay, so that is a direct thrombin inhibitor. So we're inhibiting directly thrombin, part of the common cascade. The mechanism of action is to bind directly to thrombin. Okay, so it's a direct thrombin inhibitor. They inhibit both clot-bound and circulating thrombin, which is different from no. So we said there's one drug that we can put patients on, but it doesn't change clot-bound thrombin. What was that? What? Yes, heparin, right? So this drug, why do you think that is important? That's right, so it can break down the clot, whereas heparin can't, right? So this can actually access thrombin that's bound in the clot and help break down the clot, whereas our other heparin did not. So remember that thrombin, as we know, is very central to the clotting process. It converts soluble fibrinogen to fibrin, activates 5, 8, and 10, and acts independently of antithrombin. All right, so really cool. All the hirudin products are derived from leeches, salivary glands. Well, that's pretty interesting. So that's how they created or invented heparin. Patients that were actually bit by leeches having excessive bleeding at the site. They said there has to be something in the leech's saliva who's doing this. They studied it. Sure enough, there's anticoagulant in the leech's saliva, so that can actually be, initially was extracted from there and then eventually synthetically made. The drug is renally excreted, it's monitored with a PTT, and it is, you can reverse it with dialysis or thrombin-rich plasma. So again, fresh frozen plasma, it has all the clotting factors in it, and so it's pretty dilute, right? The amount of factor 10 or factor 2 that you're actually getting in fresh frozen plasma is not that much. So you need a lot to reverse the effect of a drug. Whereas if you can get a concentrate that is just the factor that you need, oftentimes that will be much more bang for your buck, although it becomes very expensive, right? Because those are human-made recombinant factors. So these are the direct thrombin inhibitors that are from the Herudin family. So Herudin and levorudin are no longer available. Desirudin and bivalirudin or Angiomax are the ones that we see on the market currently. The indications are pretty similar, DVT prophylaxis for both, and then for desirudin, it's not recommended in acute coronary syndrome, which is bivalirudin is. We can use, again, these drugs in HIT. The half-life is a little bit different, so a little longer for desirudin than bivalirudin. We can monitor them via PTT. They're both renally excreted, and the antidote is dialysis or thrombin-rich plasma because it's a direct thrombin inhibitor. So how would dialysis work? Why would dialysis be an antidote?
Renal clearance. Yeah. Increasing the clearance of the drug.
Okay, so what does the drug have to be able to be cleared by dialysis?
Renal
What is soluble? Yes. So it has to be soluble in the bloodstream, right? It can't. The volume of distribution has to be high in the blood, not in the tissues, right? Because like you can't mobilize. If there's like a drug that's really highly, like let's say, tissue or fat bound, you're not going to probably be able to dialyze it off because it's going to be in the tissues, right? So it has to be in the blood. Okay. Activated. Okay, so protein binding doesn't necessarily, well, it can have to do with the drug. Why?
Because if it binds to the protein and it's not being in the blood or it's not being cleared out.
Well, if it's bound to the protein's in the blood, right?
Oh yeah.
It has to be large enough to be dialyzable. So there's a dialyzing membrane that the blood gets filtered through. If the particle is really small, you can't actually pull it off through the membrane. It's not going to get caught. It's just going to go through. So the actual size of the molecule is really important for something to be dialyzable or not. Okay. Also, there's a black box warning regarding epidural hematomas in patients when anesthesia is used. I think, although there's a black box warning for this particular anticoagulant, I feel like that's kind of like goes without saying is don't put someone on an anticoagulant and then stick a needle in their spine. There's a black box warning associated with bad things happen when you do that, right? Makes sense. So I don't know why there's specifically a black box warning with this versus other anticoagulants, since it would not be recommended to stick a needle in somebody's spine, anyone's spine that's on any anticoagulant therapy. Okay. Argatroban is the other IV medication in the direct thrombin inhibitor family that is not a Herudin. Its indications are for HIT and PCI, which we said is percutaneous coronary intervention. The half-life is pretty short, so it's great for if you're using it in the cath lab when you're opening somebody's vessel. It is also renally excreted and cannot be used in patients with unstable angina or hepatic disease. Monitoring is PTT, and it also, so a lot of these will also affect the PT-INR, but that's not a measure of whether or not it's therapeutic. And this needs to be gradually tapered off as the patient is put onto an oral medication for anticoagulation. So it's a little bit confusing. NOAC's a little bit confusing because there's several different names for them, right? So there's NOAC, which we said, but there's also non-vitamin K oral anticoagulant, direct oral anticoagulant, target-specific oral anticoagulant, oral direct inhibitor, or specific oral direct anticoagulant. These all mean the exact same thing. I know, it is confusing. But if you see any of these terms, it basically means NOAC, okay?
Okay.
So dabigatran is the first one that they came up with in 2010, which is really actually not that long ago. It's also a direct thrombin inhibitor and produces reversible inhibition of the thrombin. It can be used for stroke patients, so secondary prophylaxis for stroke. It can be used for treatment of patients that have developed embolism with AFib, and also for prophylaxis of development of an embolism AFib, and it can be used for treatment of a DVT or PE. For patients that are going to be treated for a DVT or PE, they have to go on a parenteral anticoagulant for 5 to 10 days. What does that mean? And why? Wake up! You have 2 more minutes.
Because you're trying to have a bridge.
What's parenteral? Good, right, so you need to have a bridge, right? So this drug is not going to be immediately effective. The half-life is 12 to 17 hours. If your patient has an active indication for anticoagulation and needs to be anticoagulated now, just like our warfarin patients, they need to be on something else for several days. Also, the question is, why 5 to 10 days? So studies show that it takes 5 to 10 days to really be at a fully therapeutic level for the dabigatran. And so the recommendation is that these patients need to have been treated, the acute clot needs to have been treated with parenteral anticoagulation to make sure that that clot is stable before transitioning over to the oral agent. So these guys are actually not bridged, they're actually treated with an IV or subcutaneous anticoagulant, either Lovenox or heparin, prior to starting dabigatran to make sure that that clot is stable. Now, they're doing some studies that may change that recommendation in the near future where you can just start this from the beginning, but for right now, that's the recommendation. So this is the dosing. I don't expect you to memorize the dosing. Just like with all the rest of the NOACs, they are renally cleared, so they require adjustment, dose adjustment for patients with renal failure. There is, now in this should not say that, I updated the slides for the direct 10A inhibitors, but I forgot to update this. So it used to be, and I think your slides might be updated, it used to be that this was the only NOAC with an antidote. The antidote is a monoclonal antibody idrusizumab, but this is no longer true. There now is an antidote for the 10A inhibitors as well. So you don't have to monitor it, which is great, but it does change the PTT and the thrombin time, but that is not a measure of whether or not the drug is at therapeutic levels. There's really no way to know that, as I mentioned earlier. Contraindications in pregnancy, mechanical heart valves, and BMI above 40 or weight above 120. So anyone tell me why having a BMI of above 40 or a weight of 120 might be a contraindication to this drug? So we see levels or advice all the time saying don't use in patients less than 50 kilograms or don't use in patients over 80 kilograms. Like, why?
Because you're having more fat tissue.
Okay, but why does that change anything?
It will affect like how the drug will be excreted, or where the drug will be at.
So where it's distributed, maybe?
Yeah, where it's distributed.
The reality is it just hasn't been studied in those patients. But yes, the question is what is the actual pharmacokinetics of the drug in somebody that has more fat distribution? Is the drug going to be changed? Is the metabolism of the drug going to be changed? But the answer is really that it just looks right in that population. Adverse effects, bleeding, and dyspepsia, and there are black box warnings about, again, spinal epidural anesthesia, don't stick a needle in their spine when they're on an anticoagulant, and early discontinuation, meaning stopping before the period of the therapeutic timeline for the anticoagulant. This is a list of the direct thrombin inhibitors. This is like kind of part of the table that I was recommending to you guys that I pulled from an article of where it's cleared, so and what the half-lives of the drug are. You can see the differences here and how they're administered. And we'll stop there for today. Let's just do a couple of the questions. We'll just do this quick case and I'll let you guys go. So an active 76-year-old woman with a history of diabetes and atrial fibrillation seen for routine follow-up asks if she can switch to one of the new oral anticoagulants that does not require monitoring for adjustment. Her current medications include diltiazem, glimepiride, and warfarin, and her INR values over the past year have ranged from 1.8 to 2.7. Laboratory studies are notable for a hematocrit of 34, creatinine of 2.7, and ALT of 33, and a hemoglobin A1C of 5.8. Appropriate management at this time includes which of the following? Switch to aspirin, evaluate source of anemia prior to switching to dabigatran, rivaroxaban, or apixaban. So we talked about one of the three of those. Discontinue warfarin and immediately start dabigatran, 150 twice a day, or continue warfarin, decreasing frequency of monitoring to every 2 months. So we said that her history is diabetes and atrial fibrillation. So why is she on anticoagulation? Why is she on anticoagulation? AFib. And what's the risk of atrial fibrillation? Why are they on anticoagulation?
Because the atrial fibrillation means they're more exposed to having more clots.
Good. So atrial fibrillation is the most common cause of embolism, right? So where do we worry about the most common place that an embolism can go for atrial fibrillation? Brain. Who says brain? So if the clot is on the right side of the heart, it's going to go to the lungs. But atrial fibrillation causes clots in which atria more commonly? The left. So the anatomy of the left atria makes clots more likely to form there. So the risk of thrombosis and atrial fibrillation the biggest risk for why we anticoagulate people is for stroke prophylaxis. So there's a scoring system that we determine who with atrial fibrillation needs to be anticoagulated. What scoring system is that? Yes, the CHADS-VAS-2 score is the most updated. So CHADS-VAS score is looking at what is the risk of that patient having a clot. So diabetes, hypertension, age, prior stroke or TIA, all of that leads to higher risk of stroke. So all of that can be used in an algorithm to figure out what is the risk per day, per year of stroke in this patient. We decided based off of her age and her diabetes, she needs to be on anticoagulation. She's on warfarin. So, should we switch her to aspirin 81 milligrams a day? So based off her CHAD score, that's a no. Should we evaluate her anemia prior to switching to dabigatran, rivaroxaban, or apixaban? So she's 76, her hemoglobin's 34. Her hematocrit is 34. Yeah, so why do you think that her hematocrit is 34? Is that super low? No. Okay, so it's on the, it's low, but it's not really low. I'm making you guys work and you're half asleep, so this is a challenge. So would you expect someone to have anemia that's on warfarin? No, unless she's bleeding. So warfarin does not cause anemia. However, anemia is caused by many things, but one of the things is because of which hormone produces red blood cells? Erythropoietin. Erythropoietin is produced in the kidneys, and she has a creatinine of 2.7. So she has chronic kidney disease. So naturally, she's going to have a lower erythropoietin level, and she's going to have anemia of chronic disease because of that. All right, so do you think that we should evaluate her source of anemia prior to switching? I would not ever yell at you for doing that, because if you're more conservative, that's fine. So that would be a fine answer, although if her hematocrit had been stable over time, we have another reason for her anemia. We don't need to work that. Discontinue warfarin and immediately start dabigatran twice a day. So we just talked about dabigatran. So why not start dabigatran? Kiara says no. Renal clearance. So her renal function, her creatinine clearance is less than 30. We cannot start dabigatran in this patient, right? It is not safe. So continue warfarin and decrease the monitoring to every 2 months. So we said that her values over the past year have ranged from 1.8 to 2.7. That's pretty much consistently therapeutic, right? So we probably don't need to monitor it as closely. So these are the kind of questions that I'm going to ask you guys on your exam. So it requires a lot of processing, a lot of thinking. So if you're sitting here thinking, what the hell is she asking? Right? So I am expecting you guys are pulling knowledge from all these classes you're taking and starting to connect the dots. Yes?
Are we going to be able to know that those are like values?
No, I will always,
Okay,
yes, right,
good.
for right now, we'll make it hormone balance. Yes, you'll have like a little. Yeah. All right, go home.
Hey. She's like, go home. I don't have a home. I'm kidding.
I know.
Look at the safety hazard.
But you should start to push yourself though. Yeah. I noticed that once I stopped throwing the balls at you guys, you were much more sleepy, so we're going. You guys that were following along my slides, was the student version updated with the?
Yes.
Okay, I was like, I know I updated that.
Yeah, I'm gonna take something like to keep doing it so you can see.
Alright, sorry.
I do.
Bye-bye.
Take it easy.
When you come back to this,
I said, baby, turn around and let me shoot that sexy
Something that's injectable or IV, having a pill that you can take at home makes it a lot easier to be able to administer. The other benefits are that there is no monitoring associated with using 10A inhibitors. There's none required. So the studies showed that based off of the doses it used within the population where it was studied, that the dose that was required for efficacy was fairly equivalent amongst populations that did not have renal failure. So renal failure is one of the populations that we do need to adjust in. If the patient was not greater than a BMI of 40, right, or 120 kilos was the number that they used. We're not really sure in those patient populations what the appropriate dose is. And because there really is no way to monitor the drug, it's contraindicated to be used in those populations. But otherwise, the study showed that in patients of all ages, if their renal function was good and they were less than a BMI of 40, giving the standard dose for those patients resulted in an efficacious anticoagulation without a great deal of side effects. So it is metabolized by the liver and the kidneys and excreted by the kidneys. So what is it used for? So it's particularly used for prevention of DVT, treatment of DVT or PE, prophylaxis of a stroke with what is NVAF.
Non-valvular.
Yeah, non-valvular AFib. What the heck does that mean? So AFib isn't in the valve, right? AFib is a result of something, right? Atrial fibrillation is lack of ability of the atria to contract normally, or not really lack of ability, but when the atria does not contract normally. So normally, right, we have the impulse that goes from the SA node to the AV node and then spreads throughout, right, eventually to our Purkinje fibers to our ventricles, and it causes this the synchronicity between the atria contracting and filling the ventricles, and then the ventricles contracting and the atria relaxing, right? But in atrial fibrillation, there's something wrong with the electrical conduction where the atria gets stuck in this electrical pathway, and it's not beating in synchronicity with the ventricles. So the atria is just beating really, really fast, but only intermittently are we getting a ventricular contraction. And because the atria is beating really, really fast, it's not filling. So the cardiac output or the stroke volume is not adequate, right? So eventually, if somebody's in AFib for a long time, they're not getting enough cardiac output to actually sustain like normal perfusion of their organs. Does that make sense? Okay, so one of the things that can induce atrial fibrillation is mitral valve disease. So if somebody has mitral valve stenosis in a wide valve area, they are predisposed to atrial fibrillation. So that was not a population that this was studied in, and therefore it can be used to prevent stroke in atrial fibrillation patients, but not atrial fibrillation patients that have atrial fibrillation due to mitral valve disease, okay? Betrixaban, as I mentioned, which is the most recently approved, is the only one that's approved for DVT prophylaxis in acutely ill hospitalized patients. So in acutely ill hospitalized patients, what part of Virchow's triad do they have that increases their risk of having a DVT?
Hypercoagulability?
So they might be hypercoagulable if they have
Surgery?
what?
Surgery?
If they had surgery, they may be hypercoagulable, but if they had surgery, they definitely have stasis due to immobility, right? And then let's say then on top of that, their surgery was due to something that was made them hypercoagulable. Can anybody think of something that makes you hypercoagulable? Think about me, what I do for my job outside of here.
Stress.
No, not stress.
Cancer.
Thank you, Brad.
Cancer. Oh, cancer.
Is that obvious?
Stress.
Cancer, yes. So cancer makes you hypercoagulable. So if you have a reason to be hypercoagulable, like cancer, or another, so some inflammatory diseases can also cause hypercoagulable states. But stasis, right? So our hospitalized patients are immobile, and therefore, in and of itself, even if they don't have cancer and don't have a hypercoagulable state, being immobile makes them at risk for developing DVT and potentially a PE. So we do use some certain techniques in order to try to prevent DVTs from forming in our hospitalized patients. And based off of what we've talked about previously, the standard of care for doing that in the hospital up until recently has been what? Okay, so there is pneumatic compression devices, right, which actually compress the legs, and they actually help the veins, right, to send blood back up to the heart, because otherwise you get kind of venous stasis or pooling in the legs. So those can be used in patients that are at low risk for a DVT, right? So we leave them on whenever they're in bed. In order to be considered low risk for a DVT when you're in the hospital, you have to be up and walking 3 times a day. So a lot of patients are not doing that, right? So up and walking for at least 5 to 10 minutes 3 times a day. So what are the other anticoagulants that are used to prevent DVTs in our hospitalized patients that we talked about last week? Okay. So warfarin's generally not used as prophylaxis. Why? It takes too long to actually become efficacious, and while we're waiting for it to become efficacious, what happens?
You need a breach.
Their patients are actually hypercoagulable initially, so not a great drug in the short term for somebody that's acutely hospitalized to try to prevent clots. I heard something over here. Heparin? Heparin. What kind of heparin?
Low molecular.
So low molecular weight heparin, which can be injected 1 or 2 times a day, which is really efficacious, and it's more efficacious than using unfractionated subcutaneous injections of unfractionated heparin. Why? It has a little longer of a half-life, so you have to inject it less.
Not a reduced risk of hit.
Very good. So much less risk of hit, right? We go from like 3 to 5% risk of hit to 0.5% approximately, 0.5, 0.6. So significant reduction in risk of hit, right? So those are the things that we generally use for DVT prophylaxis. But now I don't know if anyone's worked in a hospital as a nurse's aide or anything, but patients hate getting those injections. They really dislike it for the most part. And so this gives us an option to be able to use an oral medication to actually prevent DVTs in those patients. And that's what's unusual about the indication for Matrixaban versus the other 10A inhibitors, or direct 10A inhibitors, is that it can be used for that indication, okay? So note that. So up until May of this past year, as I mentioned in the previous lectures, we didn't really have a reversal agent. So we could give, factors to a patient that we know has direct 10A inhibition, right? But you have to give a lot of factors to overcome the drug, and it's not really super efficacious. So this drug, or this medication was developed, Andexa, which is a recombinant form of factor 10A. And so it's actually basically just replacing the factor that is inhibited in the patients. These drugs because they are highly protein bound also, we can't use dialysis to remove them because the molecules actually aren't able to be pulled out of circulation. Not much of the drug is actually freely circulating at any given time. Whereas some of the drugs that have larger particles are actually able to be dialyzed off if a patient has a toxic ingestion or a patient is bleeding. So the reversal agent for 10A inhibitors is this drug Indexo, which is just factor 10A, right, that we made. What is the reversal again that you could give for a patient that is toxic on warfarin? So you could give vitamin K, right, not potassium, but vitamin K, which K is also potassium, so we got that. So you can give vitamin K, but that's going to take a little bit longer to work, right? But how do we overcome and just give all the factors that are inhibited?
Fresh frozen plasma.
So we could give fresh frozen plasma, but that's going to take a lot of fresh frozen plasma, right? We might run out of fresh frozen plasma by the time we give enough. We could give cryoprecipitate, but we've got to give a lot of that. So how could we give factors 2, 7, what other factors are inhibited? 9, 10, what other factors? C and S, good. How can we give all of that together at one time? Yeah, so it's called K-Centra, right? So there's a drug that can be given specifically that has those factors in a patient that has an INR that's elevated, that is actively bleeding, that will work fast. You can just replace the factors immediately and transfuse the patient or infuse the patient with the factors. Okay, this is just a great little chart to help you guys remember which drugs are protein bound. So generally protein bound drugs are difficult to be able to dialyze off. The half-lives are about the same for all of the oral, or these are all the NOACs, so dabigatran's on here too, which remember is a direct thrombin inhibitor, not a direct 10A inhibitor. And then the other 10A inhibitors are on here. I put these tables in here not because I expect you to memorize them by any means, but I just think that it gives you a good reference for when you make your own tables, seeing the differences that are important between the drugs. So you get a sense for how to remember, okay, what's the same and what's different about this. So remember that we have our direct thrombin inhibitor, which is dabigatran, which is our first NOAC that was created, and then we have our 10A inhibitors. The one that's missing off here is the most recent one, which is Vitrixaban. Another cool table for you, but again, please do not focus on memorizing that. Okay. Make sure you guys know the half-lives or approximately the half-lives. And when I say approximately, know if it's like, okay, I need to stop the drug now and in 4 hours it's gone, or if I need to stop the drug and tomorrow it's gone, or if I need to stop the drug in 5 to 10 days it's gone. So just have that idea. I'm never going to ask you is it 1.5 hours or 1.2? That's just me. And most of the time for your reference is that you can look this stuff up. So if you don't remember a half-life of a drug, as long as you have an idea it's either short, really short, long, really long, that's fine because you can look up the details of the drug pretty much unless you're in some rural setting. Like when I was in India, I wish that I had actually brought a pocket pharmacopedia with me because I didn't have any access to internet, and we're so reliant on being able to look this stuff up, now because we have computers and technology at our fingertips all the time. But other than working in some rural area where you don't have access, you should always be able to look this stuff up. Get in the habit of just challenging yourself to look stuff up once in a while using your Hippocrates, remind yourself, and just so that you are familiar with the software so you know where to go when you're looking for something specific. Have you guys used Clinical Key at all? You have access to that through the library. That's a great resource as well. It's an Elsevier resource that has great drug monographs on there. Just put this back up to remind you guys, definitely know where your drugs are acting. So what is your mechanism of action? And know what makes, so fondaparinux is part of the heparin family. What makes that different from low molecular weight heparin, and what makes that different from unfractionated heparin? Make sure you know how to differentiate those things and how they act differently. We went over this case last week. All right, so let's see. Tarika, do you want to read this case out loud for us?
A 60-year-old man with a history of chronic obstructive pulmonary disease is hospitalized with community-acquired pneumonia. He is
treated with intravenous moxifloxacin in a hospital day 4 after being afibrolled for 24 hours and off of supplemental oxygen. He was switched to oral moxifloxacin. Other medications include prednisone taper, ipratropium, and albuterol inhalers, and prophylactic dose enoxaparin. As he's getting ready for discharge, this morning lab and studies are noted.
Okay. So, what do you see, David, on there that's abnormal, and what's normal for his labs?
So his white blood cell counts are now normal. His hematocrit looks pretty normal, but his platelets are kind of low.
Okay. Are they within the normal range?
I want to say negative. We are right.
They are.
So they are, right, for, like, if you just, if the range is 150 to 400, 450, right? So they are, so they're in the normal range, right? So who cares? Good. Right, so what is his baseline, right? So in the setting of infection, you can actually have a thrombocytosis, which means more platelets, right? But we really wouldn't expect to see a platelet count even over the course of a few days go from 400 to 152 unless the patient was really sick and had a really significant thrombocytosis. So that could be like on your differential, but what else should be on your differential?
Does it, I mean, because his white blood cell count also went down.
Good, good. So he was treated, right, for pneumonia. So we think maybe he had a leukocytosis when he came in because of the pneumonia, which improved. So is it possible he also maybe was really dehydrated when he came in, and so then we hydrated him and all of his cell lines dropped? Because all of them did, right? So that can account for some of it. Good, so I like where you're going with that. So maybe that's what we call dilutional. Maybe everything dropped because we hydrated him. But his hematocrit only dropped a few points, and this decreased by half, and this decreased by half. So that's like a big decrease, right? So we can justify this because we're saying we treated his infection, right? But we're having trouble justifying this. So you have a patient that has a decrease in platelets by 50% over the course of, what, 4 days? It's really fast, right? What did you say? What are you worried about? HIT. What is HIT?
Heparin-induced
Okay, so what medication is he on that could cause HIT?
Enoxaparin.
Good. What's enoxaparin?
It's a low molecular weight heparin.
Very good. Yes. So what's the other low molecular weight heparin? Dalteparin, right?
Yeah.
So Lovenox or Fragmin, dalteparin or enoxaparin. If anything, just know the generics. Dalteparin and enoxaparin. Okay, very good. Okay, so we're worried about HIT, and appropriately so. So whether or not the platelets are in the normal range or not, we need to worry about HIT if there's been a 50% reduction in platelets since starting an anticoagulant that is a heparin drug. Particularly unfractionated heparin or low molecular weight heparin. Fondaparinux is part of the heparin family, but really just only has one case report of HIT associated with it, and it's really unclear whether or not they really had it or not. But definitely our unfractionated heparin and our low molecular weight heparin. All right, very good. So what can we use for treatment of HIT? Very good. C, gargantuan. Okay. What else could we have used? So our direct thrombin inhibitors, right? So the hirudin family, gargantuan we said, and whether or not we can use our indirect 10A inhibitor, fondaparinux, kind of, the literature says yes, you can use it. Again, I've kind of told, and there's some hesitancy because it is part of the heparin family. Does that make sense to everybody?
So for the question, like warfarin would have increased bleeding, that would not make it worse, right? And so would aspirin.
Right, so remember, right, so with HIT, you have clotting, which uses up the platelets, right? We call that like a consumptive coagulopathy, where you're clotting and the factors and platelets are being taken up in the clots, which is causing low platelets. So if we used warfarin right now, so we're worried this patient, if they have HIT, they could be having a thrombosis that could be life-threatening right now. If we start you on warfarin today, when is it gonna start working? Okay, 5, 7 days maybe, okay. So what about aspirin? Right, so we're only acting on the platelets, right? And we're concerned because the platelets are low, right? So acting on the platelets and inhibiting the platelets is only fighting part of our battle, right? And inhibiting the platelets that are actually like effectively working in the case of the patient bleeds. So we have to do something about the actual coagulation factors, and aspirin isn't gonna help us there, okay? All right, appropriate management at this time includes which of the following? Discharge home with an appointment to follow up a CBC in 4 days. Discharge home on aspirin, 325 daily for a month. Discharge home on warfarin for a month with follow-up monitoring for an INR of 2 to 2.5. Or keep him in-house, start agatrovan, and transition to warfarin as platelets normalize.
D.
There you go.
So just, can I get some clarification?
Yes.
So you said you use argatrovan for the treatment of HIT, but then I just remember on the slide it said second next to it. So is that not implying like, what is that implying?
What's that second?
Is that like the second time we had HIT, or like in the slide it
Oh,
said?
I think it meant type 2.
Type, what did you say?
Oh, type
Type
2
2.
HIT. Yes, I was like, what?
Oh, okay.
Yeah, so remember type 1 HIT is really minor. It goes away on its own.
Oh, okay.
And you might not even notice it because you
Okay.
don't have a significant decrease in the platelets. Whereas HIT type 2 is when you see that 50% decrease within 7 days of starting that.
Okay.
Thank you. I was like, I was just blanking on what slide you were talking about, so thank you for clarifying. Alrighty, that's that. So we finished anticoagulants. Let's move on to fibrinolytics.